all I know, love will save the day. Got to be bold, got to be bad, got to be wise, don't ever sad, got to be hard, not too hard. All I know is love will save the day. You gotta be bad, you gotta be bold, you gotta be wiser. You gotta be hard, you gotta be tough, you gotta be stronger. You gotta be cool, you gotta be calm, you gotta stay together. You gotta be bad, you gotta be bold, you gotta be wiser. You wake the wild-hearted rebel in me. You rev me up like a ride in the sea. I know that without a doubt, ain't slowing down. Yeah, I always find the beat. Never quit, never let me down. Oh, you keep me standing on higher ground. I feel the love. I feel the love. I feel the love. I feel the love. You got such a beautiful thing. We got such a beautiful thing. We got such a beautiful thing. We got such a beautiful thing.
Good morning. I'm Dave Herbal, and welcome to our first completely virtual Leadership Institute. Before we get too far along in our introduction, I'd like to thank Monica Levin for her interesting thoughts on the use of body language and remaining open to new ideas. I'd also like to send out a big thank you to Bobby Kyers for her creativity and hard work in creating that tremendous tribute video to all of our members entitled Serving with Grace. I cannot think of a better way to kick off our 2020 Leadership Institute than the celebration of our members. This year has been unique in every way, and we've worked extra hard to design and bring to you subject matter experts on everything from the economy to building census to developing policy initiatives and becoming unmistakable. You also will have plenty of time to network and collaborate with our valued business partners and enjoy a Leading Age Michigan's annual business meeting that begins tomorrow morning. During our business meeting, we're also going to have some time to celebrate some of our most deserving 2020 award winners and make a few major announcements. So without any further discussion, let's get Leading Age Michigan's 2020 Leadership Institute underway. It's my pleasure to introduce to you this morning Dr. Robert Gordon. Dr. Gordon serves as the director of the Michigan Department of Health and Human Services, where he oversees Medicaid programs, children's protective services, food assistance, public health, and many other statewide health and human service programs. Dr. Gordon was appointed to his position in January of 2019 by Governor Gretchen Whitmer. Dr. Gordon's had a distinguished career in public service, most recently having served as the Senior Vice President of Finance and Global Strategy for the nonprofit college. Prior to joining the college, Director Gordon served as the U.S. Department of Education and Acting Assistant Secretary at the Office of Planning, Evaluation, and Policy Development. He spent 4 years as the U.S. Office of Management and Budget, including service as the Acting Deputy Director. He's been described as a quarterback for President Barack Obama's administration's evidence-based policymaking initiatives, which closely tie program funding to quality initiatives. Director Gordon's leadership and collaborative style has been instrumental in Michigan's success in our fight against the pandemic. Dr. Gordon and his team have demonstrated the kind of leadership that will help us prepare for a second wave or any other health challenge that might face our great state. Director, it's my pleasure to welcome you to our 2020 Leadership Institute, and thank you for joining us today. Dr. Gordon.
Thank you, Daddy. It's great to be with you. I wish we were in another way, but great lesson. I'm going to a little bit, and we'll be happy to take some questions. I want to thank Dave for the kind introduction and also for the leadership and input that he has provided over many months now, including most recently through his service on the task force. I'm coming up on 2 years at MDHHS. One of the first things that we did in my first year was to lead an exercise on our values, and we decided that an organizing theme for our work would be the value of hope. And hope, each letter stands for a different value: human dignity, opportunity, perseverance, and ease. And I'm told perseverance is your theme at today's conference, and obviously it has taken on a whole new meaning this year, far beyond what any of us imagined. And I think particularly for all of you who care for and are involved with Michigan's aging population. We have faced challenges like none of us ever imagined this year. And I think we have all asked ourselves, I think, two things. One is, how could this be happening? And the other is, what can I do to address these challenges? And I know that each of you has played a part in tackling this crisis and in protecting and saving lives. And I want to talk a little bit about the efforts that we have made at the department to address challenges, to learn from our mistakes, and we all make mistakes, and to find ways to make progress in the face of enormous difficulty. COVID has shown us challenges that have existed for a long time, challenges around racial and economic inequity, and challenges around inequity in the way that we treat older Michiganders and older Americans. Individuals over age 60 are about a quarter of Michigan's population. They are about a third of COVID cases nationally, but more than 80% of deaths. And this is why we have to continue to work together to address the challenge of COVID. And we always have to work with one thing in mind. It's been the goal that has animated us since the beginning of this crisis, and that is the goal of saving lives. And I think if you look at the long arc of COVID in Michigan, and sadly it is long right now, the level of loss of life that we have experienced here has been tragic. It has been profound. I think the loss of life in nursing homes in particular has been tragic and profound. And at the same time, I think we have made enormous strides, and you can see those. You can see those on the ground in the work that each of you is doing, and you can also see those in numbers in the data on levels of cases and levels of fatalities over time. So I want to talk a little bit about that. I think from the beginning, I'll talk first a little bit about our COVID response generally in Michigan, and then I'll talk more specifically about challenges for older Michiganders and nursing homes. We have based our response on a three-pronged approach. The first is ramping up screening and testing, including in long-term care facilities. The second is education and promotion of proven public health interventions until we have a vaccine. And the third is coordination of resources, data, PPE, and efforts across different state agencies, with the governor's office, with clinicians, with local health departments, and with healthcare partners like you, to make sure supplies are needed where they are. As I said, in the spring, Michigan faced one of the most terrifying surges of COVID in the country. At one point, we were the #3 state for deaths from COVID. We faced a situation where cases were rising at an extraordinary exponential rate, where we were working to build capacity for testing, yet we were able to do very little testing, 5,000 or fewer tests per day in March and April. Whereas I don't have to tell all of you, we faced shortages in PPE and in staffing. And where we were working in this context, our hospitals were facing such a surge in cases that they were facing an imminent shortage of beds. And this was a time when I think the level of loss of life in Michigan was particularly great, and the level of accompanying tragedy was particularly great. But it's worth comparing where we were then with the road that we have traveled since. We've gone from about 5,000 tests a day then to about 30,000 tests a day right now, with, as all of you know, a particular focus on regular testing in nursing homes. I think Michigan now ranks 10th or 12th in the country for per capita testing. So we have been able to ramp up extremely quickly. I think when it comes to staffing, we have worked hard to enable this and to support the provision of adequate staffing resources. I think all of you nursing homes have first responsibility around staffing, but we have a role to support you in a period of real shortages. So we've offered rapid response staffing resources in 11 counties that provide emergency resources. Working with the Department of Labor and Economic Opportunity, we've set up a portal focused on healthcare jobs, both in hospitals and in other facilities, including nursing facilities. The Nursing Home Task Force provided a number of recommendations about actions we can take over the longer term to increase the number of people who enter healthcare professions and enter, in particular, the profession of working in facilities like yours. That will be a long-term effort, but one that we are committed to. We have built our PPE capacity initially through donations and working with the federal government and very rapid purchasing at the state level. By the end of July, we had distributed about 187,000 cases of PPE. We have brought dramatically down the number of facilities that are reporting any kind of shortages at all. And when we hear those reports, we respond to them quickly. We have worked with other institutions like FEMA to provide for direct shipment of PPE. We are enabling the provision of resources through local emergency management teams and healthcare coalitions. We've been working with the CDC and manufacturers and distributors to replenish and increase the strategic national stockpile storage capacity for Michigan in the event of a second wave. We're distributing the $25 million from the legislature for PPE purchases. So I believe we are in a much better position than we were months ago, but we must and are committed to remaining vigilant to address any shortages that arise. I think hospitals, of course, are in a dramatically different position, which means that they are able to treat individuals who are in need of care. Back in April, we contracted nursing homes to help care for COVID patients through the regional hub model. By May, that had opened up more than 600 beds for COVID-19 patients, relieving strain in other parts of the healthcare system. The hub model is one that allowed for the transfer of patients from other nursing homes or discharges from hospitals. We required hubs to meet standards for quality and safety. The decision to use hubs is one that has received a lot of scrutiny. Many people have said this was a mistake. I think if you look at the data on the hub performance, and there was a new report out yesterday from CHART, the Center for Health and Research Transformation at the University of Michigan, the performance, what CHART found was that hubs were a logical and appropriate response to the challenges we faced, and that the performance of hubs was solid, that you had a lower level of fatalities in hubs than you had in nursing homes, which I think does not support allegations that hubs were ineffective. Having said that, we are profoundly committed to improving in all of our work. I've talked about the commitment to improving access to staffing and access to PPE. And similarly, we have continued to make adjustments in our guidance around hubs, including requirements around dedicated units, testing of transferred patients to confirm COVID status, and shifting some decisions regarding a patient's location preference to the local level. So I think we have evolved the hub strategy, and we will continue to do so. There are recommendations that have come both from CHART and from the Nursing Home Task Force, which we are committed to reviewing and to acting on I think one issue that I know is of particular interest is visitation. There were a number of recommendations around the quality of life at nursing homes from the nursing home force. We will be issuing an order later this week that will speak to some of those recommendations and allow for additional visitation in nursing facilities, provided it is under very strict protections, things like outdoor visitation. More to say on that soon. Obviously, serving older Michiganders is not just about improving nursing homes. It is about a whole range of services that we provide for our older population, including enabling folks who can stay in their homes to stay in their homes. One of the challenges that is a constant here is the availability of direct care workers. And it's estimated that Michigan needs 34,000 more direct care workers than we have, in part due to shortages, in part due to our population. Obviously, a huge challenge in the availability of workers is what they are paid. And provided additional funding for a $2 an hour wage increase for direct workers as part of legislation enacted during COVID. We will need to find term solutions to extend the workers. Our team, our Adult Services and Aging Administration, led by Dr. Alexis Travis, is working all the time on ways to provide better resources. This includes area MyBridges referral agencies and navigators. Dr. Travis has been working with many of you on the formation of the Direct Care Workforce Advisory Committee that's aimed at supporting the provision of additional supports for direct care workers and additional supports for older Michiganders so they can make decisions about what is right for them. So I think if you look across all of our work, we all mourn the loss of life from COVID. And I think, unfortunately, the challenges that remain in front of us are real. We are, I don't tell you, as the weather cools off, people will move, and that will create additional pressure on COVID cases. We have kids going to school, we have kids in college, that will create additional pressure on COVID. And we have flu season coming. So the challenges in front of us are real. I believe we have taken over the summer, we have moved prudently to take the steps needed to ensure that our nursing home partners have access to the PPE, to the staffing, to the supports that they need. I think we are committed to continuing to act, being as responsive in real time as we can be. As I said, I believe our performance to date, if you look at it in national context, if you look at the loss of life here compared to in other states, I think what has happened in nursing homes, while tragic, I think there are many places that are in a much worse position than Michigan. And we will continue to do everything in our power, working with all of you, working with Dave, working with Leading Age, working with you as the real leaders on the ground to do as much as we can to protect life and to honor life, not just now, but in the future. So thank you for all that all of you do. Thank you for listening to all this, and I'd be happy to take questions.
Thank you, Dr. Gordon. I will wait as we type in some questions here in the questions panel or in the chat panel. All right, we have a question. What other health dilemmas do you see occurring in Michigan, and what other policy goals do you have for health policy going forward?
So I want to say, do you have an hour? But thanks for asking that. I think in the near term, we are focused on reducing the loss of life from COVID. And that has multiple dimensions, but that has to be top of mind for all of us. And that means continuing to test, continuing to trace, continuing to support information for the public around the need for masking and social distancing and good hygiene. And that will be our focus. I think if we look deeper at the causes of some of the disparities we have seen from COVID, and in particular the horrible racial disparities in loss of life, I think it forces us to focus a couple ways. One is simply on racism and the role in our society, and it's not limited to Michigan by any means, but the role in our society, the lasting role of discrimination in access to healthcare, in access to things like housing and food and employment that are the social determinants of health outcomes and the foundation of health outcomes. And I think we at DHHS have a particular role to play in opening up access, whether it is things like promoting training and requiring training for our staff and for medical professionals on implicit bias, or getting out there and providing better access to food and shelter. I was super proud that Michigan was the first state in the country to provide a massive expansion of SNAP benefits, food assistance benefits for parents. That may seem far afield, but actually we all know that access to food is critical to health outcomes. So that's another piece of our work, is addressing social determinants of health, addressing racism and the consequences of racism in our healthcare system. I think other goals that, before all of this happened that remain central for us are things like addressing maternal infant health and reducing disparities in maternal infant health outcomes, addressing the impact of lead in our water and for our kids. Prior to COVID, I would have said that lead remained the central public health challenge facing our country and our state, and something that we can still do much more to address. And then I'll just say it's a time of, and this is not fun to talk about, but Michigan has real budget challenges, and we have to address those challenges. And we do always have to think about, are we using dollars as effectively as we can? Dollars being spent on things that they shouldn't be spent on, places where we can reduce spending and shift it in order to be more effective. So hope that's a good answer for you.
Yes, thanks so much. We have a number of comments that would like to thank you for your upcoming order on visitation. People are very excited about that. Another question that we have here, how do you see the upcoming election working for those who are in places with restricted visitation in terms of their ability to vote?
That is such a great question. And I am not an expert on voting. I will say that, Michigan, in my view, is fortunate to be a state that has enables anyone to get a mail-in ballot, no excuse mail-in voting. And I think for people who are mobility restricted, the focus should be apply. You can go now, you can request your mail-in ballot now, you can send it in as soon as you get it. You can go online and check and make sure that it was received and make sure it was counted. And I think I would just encourage all of you, since I don't think you want for folks having to go vote on election day, is just to support your residents to go through those steps to make sure that they get ballots in plenty of time. Obviously, I have to get into all the stuff about the Postal Service, but get their ballots early, go through the process, do it. And it's not the simplest process in the world. So take your time with it, go through it, make sure you've done it right. And then I think on a smartphone, you can just go on this. Actually, I've seen this myself. You can go on a smartphone and see if you voted. And so I think that's all stuff that people are able to do.
Excellent. Thank you. Our next question here. The workforce struggle is real in direct care. Are there any new proposals for additional pass-through funding for this workforce? Today, even the $2 increase in some areas, we still see people in our state receiving more unemployment relief than we are able to pay as providers. This leads to very real, difficult business decisions about continuing our ability to serve our seniors.
Yeah, it's a great question. We would love to be able to extend the $2. I think it's going to run into it's a very expensive thing, and it's something we're talking to the legislature about. And I think longer term, there is a need to, I mean, there are things that we will do like advertising and career pathways, making sure that folks who enter this field, if they stick around, have an opportunity to earn more than entry-level wages. I'm sure that's something that you all work on. It's something that we would like to work with you on. And then longer term, I just think that this actually ties into issues just about the level of revenue that the state has and how much money we have to spend on the things we need. And it's very challenging. Michigan, that even before COVID, the level of revenue that the state was drawing was essentially in nominal dollars, I believe, the same as it was 20 years ago, which means that in real terms it was down significantly. And that's not a way to meet the needs that we have as a state.
Thank you. We have a bit of a lighthearted question here. As a newcomer to Michigan, what do you like best about becoming a Michigander?
It's a great question. I love how beautiful the state is and how I feel like on weekends, particularly with COVID, I've been fortunate to be able with my family to travel to different places. And we really have been sort of all the way around the mitten this summer, from Bay City up to Petoskey and Charlevoix, over to like New Buffalo, and just have done a lot of, just my boys love to swim, and I've been able to get them out swimming, and that has been delightful. I should say I am personally a born and bred city person, and have felt lucky to be able to visit Detroit a few times. Obviously, it's not the same in the middle of COVID, but we'll be very excited when we get through this to spend more time there as well.
Excellent. Well, I know you're very busy, and that's all the questions we have for today. So thank you so much for your time and your comments. And we really appreciate you taking the time out of your day to address our members and the time you spend helping Michigan seniors throughout the state.
It is my pleasure to be with all of you. I want to say thank you again for the work all of you do. I know it is out of the spotlight. I know how difficult it is. I should say my own parents recently went from their home to a nursing home. So I got to hear about, in the middle of COVID actually, so I got to hear about and talk on the phone. And it wasn't here, but just to the number of people I met who were doing just wonderful, caring, compassionate work with people facing real challenges, I was very moved by, and I know that's the work that all of you do every day. So let me just say thank you.
Thank you so much. We'd also like to thank your team, Kate, Brian, Aaron, and the many others over there at MDHHS who put in all these long hours and work very hard to help support us and Michigan seniors. So thank you again, and thank you for everyone. We're going to move into a short sponsor break. Our next sessions begin at 10:50, I believe, or 10:55. Hello, everyone. This is just an update. I forgot to let everyone know that we'll be having two different sessions coming up. One at 12:55, one in this room. In this room will be an innovative approach to manage care plans. And in room 2, we'll have Become Unmistakable. Please feel free to either move to room 2 to view Become Unmistakable, or stay in this room for an innovative approach to manage care plans. This is room 1.
welcome back, everyone. I believe you can hear me now. Sorry for the sort of the long, I guess I would say the long break and the miscommunication over that last break. We were anticipating that to go to 10:50, so it did throw us off a little bit. As you can see, you have stuck in room 1, which will be an innovative approach to managed care plans. If you did plan on being in room 2, which as of right now is become unmistakable, you will need to go to the bottom right of your screen where it says leave, and you would have to click on that. That will take you out of this, and you'll go back to the agenda, and then you can just click on become unmistakable room 2, and it will take you right in there. That's what you'll do for all the sessions moving forward. So next in room 1, we will have the virtual expo, which is where everyone will be. But then after that, if you want to stay in there, we will have Michigan's regulatory environment. Or if you don't want that, again, you will just need to leave the room, go back to the agenda, and then you can choose the other session that is going on concurrently as well. So sorry about that. But now we will get right into this. Welcome to our innovative approach to managed care plans presentation. If you have not done so already, please make sure your first and last name appears correctly, as this is how your attendance is tracked for continuing education hours. To change that, I believe you can click on either, I think, the participants or your name, and you should be able to click on more, or there should be 3 little dots, and you can click on that and change your name if you need. My name is Blake Weller with Leading Age Michigan, and it's my pleasure to introduce our panelists. Each member of the panel has an in-depth knowledge of operations and implementation of managed care plans. Ally Align Health has the first national company focused on enabling senior housing providers to transform the quality of care for their residents through Medicare Advantage risk products. They operate an active care management platform that enables real-time cross-boundary collaborative care, as well as connect residents and patients with chronic and complex medical conditions to care teams, providers, and home and community-based services. Now, to introduce them, Steve Kastner is the president and CEO of Trinity Health Senior Communities. Trinity Health has partnered with Ally Align Health as a long-term care provider for the sponsored Medicare Advantage Special Needs Plan. Will Saunders is the founder and CEO of Ally Align Health. Will has a passion for reforming the healthcare system to more efficiently and effectively care for vulnerable and medically complex residents and patients. Amy Kazik is the president of Special Needs Plans with Ally Align Health. She played a critical role in helping start the company in 2013 with founder Will Saunders. Greg Bryant is a senior vice president with Ally Align and an executive director for Align Senior Care. And now it will be my pleasure to turn the mic over to our panel of experts. Just one last thing I did want to say. I will only be here till about 11:30. At that point, we will need to have Dalton take over. So if you can make Dalton a panelist as well, that would be greatly appreciated. Thank you, and it is now take it over.
Hey, good morning. This is Will Saunders. Are you going to share a screen with me or with Amy Kazak? Is it shared?
I believe you should be able to click on in the bottom left of your screen. There should be a share screen button.
Yeah, it's not allowing us.
Yeah, it says host disabled participant screen sharing. So.
Hey, Brian.
Yeah, try it again. It should be working.
Okay, great.
And then just start your slide full screen.
Yep. Okay. Which one is that? This one. Okay. It would not be a virtual event these days if we didn't have some connectivity issues. So hopefully that's behind us. So I'm Will Saunders. I am so grateful to be speaking to you today. I'm grateful for our partnership with Trinity and Steve Kastner, who I know will be speaking in a moment, and I'm grateful for Leading Age to give us this opportunity. So you may have heard of Ally Align Health. We have a model that we are passionate about, which is we leverage the Medicare Advantage Authority to deliver a care model within senior housing. And I like to say to people, we are not in love with the Medicare Advantage program or special needs plans. We are experts at operating them. What we are passionate about is accessing the premium dollar directly and sharing those savings with their senior housing providers so that a clinical model can be delivered within senior housing that drives quality, drives member satisfaction, drives family satisfaction, and economic benefits back to our partners. So we've been doing this for a while. We are a national company. We have plans in over 22 states. And there's some principles to our success. One is financial transparency with our senior housing partners. This is all that we do. So we do not operate other types of services or MA plans or commercial plans. We are exclusively focused on delivering a care model within our MA and special needs plans to our population. And we have had a great deal of interaction with CMS over years over our model, and we're excited about how they view our model and the innovations that they're thinking about with respect to. So you probably all have seen these slides before, but we really view things as kind of pre-COVID and post-COVID. So pre-COVID, and we expect this trend to continue. I think the key takeaway from this slide is Medicare Advantage is growing. There's more knowledge of it amongst residents and their families, and they are all more and more aware that there are plans that can offer them additional benefits and additional capabilities. There's still a great deal of confusion about Medicare Advantage in the market, but we are on a trajectory to have over 40% enrollment. And I think that also speaks to the durability of Medicare Advantage in terms of our society and CMS relying on it going forward. So why are senior housing organizations interested in MA, the ones that we work with? So I think the first dynamic is Medicare, and those of you who have Medicaid or dual eligible residents, Medicaid is covering more and more of the healthcare spend, and the traditional fee-for-service economic models are under pressure, whether that be your therapy programs, whether that be your home health. If you have a SNF in your life plan community or you are a SNF provider, I think we're all very familiar with those trends. So something that we see is a great deal of growth from a memory care perspective, and we operate a chronic needs plan just for dementia, and we're proud to say that we operate the vast majority of those plans that are approved around the country. And we all know that the dual eligibles are increasing every year within the long-term care system. I think something that we figured out, we can pat ourselves on the back 6 or 7 years ago, is senior housing is a critical link in value-based care. But I think it's fair to say that is not really appreciated by the average health plan, the average MA plan. So our passion, again, is using the MA authority to help our partners. So in the new normal of COVID, you know, a year ago, I would meet senior housing providers and a lot would talk to me about a hospitality model, a social model, and they would have a, constructive debate about, do I really want to engage on the clinical side? Do I really want to engage in our model, in Medicare Advantage and managed care? And I think that what we've seen the past 90 days is that has completely transformed. And our partners, first of all, I'm not telling you anything you don't know, certainly have a need to keep the resident and their family safe and protected and deliver a higher level of primary care within their community and within their campus. And obviously, we view the value of our plan as funding that primary care model. I know many of you have probably tried to have a fee-for-service primary care model in your communities, and you really can't most of the time recover your costs just on a pure fee-for-service basis. So the value of our model is a funding stream for that primary care focus. And then the provider perspective is obviously you want to fund that for your residents and your families and fully support that clinical model as a core component of your offering going forward. And certainly families and residents are more and more demanding in the new normal of COVID for that clinical approach. And I know Steve and Amy will talk about that in a moment. So again, I am grateful for the partnership with Leading Age, with Trinity. We are passionate about what we do. You're going to hear a lot from Steve, Amy, and Greg right now. And we are just grateful for the opportunity to present our model and our mission. And I can tell you that it is transformative for the members and families we work with. So with that, I will turn it over to Steve.
Thank you, Will. Appreciate that. And I too am very passionate about this program and appreciate the opportunity to be here today to talk more about that with the group as well. The why for us, why do we become involved in this? And it boils back to our mission statement. And it's about being a people-centered health system and a healing presence in our communities. And that's really the source and the reason why we became interested in helping to be a part of growing the ICENET program in Michigan. We also know that we have a special interest in making sure that the people who choose to come to live with us, the people that are in our long-term care side of our nursing home and our assisted living communities are being cared for. And lastly, there's lots of interest, as Will talked about, with Medicare Advantage plans, and we've all seen the growth throughout the country and even in the state of Michigan with Medicare Advantage plans. And we were on the opposite side of it. We wanted to be more on the side where we were being proactive and had a stake in that future growth of Medicare Advantage in our state and be a partner in that program. So those were the drivers for us in terms of the why we decided to get into the program. So it started with discussions back in the summer of 2018 with Will and his team about how could we implement this program in Michigan and which counties should we be focusing on in terms of rolling this program out. Will and his team were very flexible in terms of what role could we play in the program. We had early discussions about being a partner in the ownership of the ICENET program. But at the end of the day, we opted to not take an ownership stake in the ICENET program in the state of Michigan, and are really on the vendor side, the implementing it for our residents aspect of this. There's always an opportunity down the road to revisit that discussion, but at this stage in the development of the program, we didn't feel like we wanted to take the risk on of growing the program and being a part of that side of it. So the program really was rolling out starting in the fall of 2018 and 2019. We started enrollments in October 2019 in our communities. We set targets to grow the program, and prior to the COVID situation, we had enrollments of up to about 175 of our residents in the program. And today, that number, due to the COVID impact, we're down to about 120 at this point, and looking to grow that number over the next few months back up to the 250 to 275 range within our communities. So our experience, what have we experienced so far? And I think everyone knows on the call, I'm not telling anybody that's something they don't already know, but when the opportunity to have a nurse practitioner in your building on a regular basis, monitoring and caring for the oversight of your residents is tremendous. She's there and offering insights to our staff, giving them tips and steps on how to manage the day-to-day care of that patient, and making sure that we're avoiding hospitalizations as much as possible as we go through the program. One of the advantages we've seen as a result of our partnership as well has been the opportunity to skill in place, particularly during this COVID situation we've had in the last few months. an opportunity for a person, one of our residents not to have to go to the hospital and have 3 midnight stays. They're able to be skilled in place right there in our building and take better care of them going forward, not having the opportunity to risk the safety of them leaving the building and experiencing other issues as a result of that. The nurse practitioner is available to us 24/7. She coordinates the care at all times for our residents and really becomes a team member for our staff in the building in the oversight of the care for those individuals. It's been a tremendous experience so far. No issues from a mission standpoint. Very flexible coming on board and working with our teams and being understanding of the care in the world that we operate in our different mission-based organizations.
Well, Steve, thank you very much for that overview of the relationship and how Ally Align Health has worked directly with Trinity to date. So the 3 key elements of the Ally Align care model are: number 1, on-site primary care. So making sure you have safe, convenient care for our plan members and your residents. Number 2, and this may be the most important one, is a senior housing partnership. So like Steve explained, Trinity is not an owner in the plan, but they are a significant, engaged, risk-bearing partner. And I'll talk more about what that risk-bearing partnership looks like and what it means. And then finally, critical to our model is that special needs plan. Whether it's an I-SNP or a C-SNP or a Medicare Advantage plan, it's really that Medicare Advantage plan that funds and enables the partnership and the on-site primary care. When we bring all of these components together, so the plan plus the care plus what you are already doing in your communities, we're able to work together to improve outcomes. That includes reducing avoidable hospitalizations. Steve mentioned the skilling in place, keeping residents on your campus as safely as possible for as long as possible. And finally, improving family and resident satisfaction. Working together, we can enhance care through that preventive model that is delivered on site in your campus. We also bring in a family and member portal, telehealth services, and we can improve safety and again, convenience and access. Reducing fragmentation is part of what we do with you. So in our model, our care team, our medical concierge, nurse practitioner, advanced plan practitioner connect directly with your wellness team, with your nursing staff, with your health resources, and really involve you in coordinating with care plans that are comprehensive and that also connect out to our ancillary providers, home health and therapy, for example. And finally, with the plan, we're able to offer more than original Medicare. So improving outcomes, enhancing care, reducing that fragmentation, but also offering tangible benefit design with your residents in mind. So just a little bit about our on-site care model. Our model is flexible and we work with residents in all living levels. So our model is designed to work very well in standalone nursing and SNF facilities. We can work in standalone assisted living or memory care communities, and we can work in standalone independent and even affordable housing communities. What I have on the screen today, though, is really that CCRC or life plan community mixed living levels is how I would describe it. And talking about how in our model, we're able to bring on-site primary care for all of your residents with specialized services for your highest risk, most vulnerable. So if you're thinking about your CCRC setting, door number one, if you will, to the care model is allowing your residents to access the clinic, access the nurse practitioner for sick day and as needed visits. This is ideal for your low-risk residents who already have primary care teams, et cetera. They are looking for convenience, they're looking for safety, they're looking for improved access. We work with all insurance plans, not just Align Senior Care. So we will bill the residents' insurance, and that's probably their initial introduction for many of your residents to the Align Senior Care practice. We offer a second tier, our concierge practice membership. This is ideal for, we call them your rising risk members. You know who they are. So maybe they don't qualify for our plan, and we'll talk about the eligibility in just a minute. So they might not qualify for the plan, but they still need some extra help. They need help coordinating their appointments. Maybe they need some extra time, extra attention. They need education. They need family care team meetings. We can help do that with them. We charge a true concierge fee. This is at the practice level. We have full family engagement, care planning, care team, condition monitoring, all of those things that your rising risk members may be looking for. And then finally, we have plan membership. So it's everything you can access, that full on-site primary care, all of those concierge level benefits. And it's designed, again, for your higher risk residents, but there is zero concierge fee. So we are able to offer through Align Senior Care and membership in the plan, concierge on-site primary care without the concierge fee. Our care delivery team on site with you is titrated again to the living levels that you offer. We always have what we call an advanced plan practitioner or advanced plan provider. That's just a shorthand way of saying a nurse practitioner, PA, or primary care physician. They are contracted with the plan. They are responsible for primary care services and what we call model of care services for our members. So this is the clinical team member of that on-site primary care, either rounding model, we will see residents in their rooms, or that true clinic space model. They are manning the clinic. We augment with a care navigator. Our care navigator is really designed to support our advanced plan providers, our residents, and your staff for plan members who are in the SNF or maybe standalone assisted living residents and campuses. They're responsible for helping members, practices, and communities access plan resources and coordinate care and services. And then finally, our medical concierge. This is that position that we were talking about. They are really the liaison with your wellness team, with the care plan. They're facilitating a lot of the interaction with members, and they are typically a licensed medical assistant or medical tech. So they can support your wellness team as well as the advanced plan provider with some basic medical care services. Our model offers real benefits to you as the community. We have a funding stream for your on-site care team, so we're able to bring in that primary care. We work with you, like Steve said, to make sure that we are very cognizant and aware of your mission, your philosophy, the lifestyle that you are offering to your residents. We want this to be a part of what you are already doing and to fit in and really enhance maybe sometimes the reason why residents chose you as their housing option in the first place. We offer you, this is the engagement and that partnership risk. We do engage you in profits of the plan. So you can call it gain share, you can call it a quality incentive. It is quality based, but it's based on how well we take care of your residents together. And then you can also use the plan, obviously, to support your marketing efforts. This can be a differentiator many times for your campus. And it also allows your most vulnerable residents to stay on campus for as long as possible in a safe environment. Our enhanced reimbursement for our community partners is made up of two main sections. The first one is fee-for-service payments. So if you are a CCRC or a SNF nursing facility, your Medicare reimbursable services are paid by the plan for members who are enrolled in Align Senior Care. So you get paid 100% for what you are already doing today. Same way if you have outpatient therapy and home health partners, or if you provide those services directly, those are paid at 100%. And then what we add on for you is we add on those quarterly incentives for pay for performance for quality. And we tie those quality incentives back to overall HEDIS measures, but also how you engage with us as the plan. Are we doing those care team, care planning meetings together? Are we truly coordinating care? And are we doing that job of keeping your residents as well as possible for as long as possible on campus? And then we have an annual quality payments that's based on the overall performance of the health plan. So you are not an owner in the plan, but you are an owner in the outcomes, meaning that as we work together to create improved quality and utilization metrics, you share directly in our success as the plan. And that allows all of us to continue to put money back in to the services that we're providing, again, for our members and for your residents. We also offer real benefits for our members. We have that plan practitioner that we talked about, so the on-site primary care. We make sure that we are paying attention to the acuity of all of our residents. We see some of our members as often as weekly if needed. Remember, there's zero copay or coinsurance for these visits, so they may be seen once a week by a nurse practitioner in the clinic or in their home setting, and they have no out-of-pocket cost for that. We're available 24/7 through call, and that includes weekend availability as well as after hours and holiday availability. We, of course, have in-person enrollment and customer service support. When we say in-person these days, that might mean more like face-to-face, like we're doing now. We do have full telehealth capabilities and what I would call teleconnection capabilities. So we can offer health services via telehealth, but we can also offer enrollment and plan services if there are questions for your residents directly face-to-face via our Gracie platform. Our plans, Greg's going to talk a little bit more about exactly what Align Senior Care is, but we do include a full Part D benefit. So our plans are full Medicare Advantage plans covering all Part A services, all Part B services, and that Part D drugs. And then we also offer real supplemental benefits beyond original Medicare, just like all of the other Medicare Advantage plans do. However, we worked extensively with Trinity in that 18 months before Plan Go Live, and we continue to work with our partners like Holland Home to really understand what do our members need, what is going to best serve them as residents on your campuses. So today we have dental, we have some vision benefits depending on the plan that you choose. Podiatry is very standard, so these are additional benefits over and above original Medicare. And then again, diabetic supplies and health products catalog. So before Greg jumps into the details of the plan, I just want to make sure that we're all level set a little bit on the components that we're talking about, and also how does this really work? How are we able to pay you back and really involve you in those, not just quality metrics, but in the overall plan outcomes? And how does your team, how do you help achieve those outcomes for the plan and ultimately for your residents? So as a Medicare Advantage plan, Align Senior Care, we are paid a capitation amount by Medicare. So for every enrolled member each month, we get a set fee from CMS. That fee is risk adjusted. So the first thing that you can help us do at the plan level is make sure that we're working together with our nurse practitioner teams to risk stratify and risk adjust every member who joins the plan. There's a process for that. Steve can tell you more about it, but we go through that to make sure that we're all paid correctly from the get-go. After that, you can see this shows the breakout essentially of the different types of, where does that premium dollar go? And that's another benefit of working with Ally Align for all of our plans. We are very, very transparent. So you see this breakdown for your resident population. You can tell where the dollars are going, and that empowers you to help us understand about what can we do with our clinical teams to help best direct the dollars to the right places. So typically what we see for a senior housing resident is we're going to have about $300 to $400, and remember this is on a per member per month average, but about $300, $400 of the premium goes to inpatient hospital. So anything we can do together to help keep your patients on campus means that those dollars are not going to your friendly community hospital maybe quite as often, but instead they are kept for the plan or potentially can be paid back here to you as part of that quality incentive. We have about $400 that we focus, again, on post-acute SNF Part A services, or those what we call skill in place or skilling in place services. So these are dollars that we are paying as the plan generally to you, maybe through your SNF, maybe it's through Part B therapy, it could include home health services, but these are all of the things that we're doing together to keep your members on and residents on campus. And notice here that this post-acute or sometimes even pre-acute spend is just about the same as the hospital spend. We really do believe in a preventive model, and we show that by putting more dollars here and appropriately caring for patients and preventing those acute hospitalizations. We save money here and put more dollars appropriately into the pre or post-acute bucket. And then finally, we've got this big bucket again that is mostly primary care. It includes specialists, maybe diagnostics. And again, this is where we do want to invest our money, these $2 where we are preventing the hospitalizations and acute exacerbations, because this is what's keeping your residents well, active, and satisfied. We do have dollars here for Ally Align Health. This is where we are paid for our administrative fees for the plan, but also the reserve requirements that we have to have at the HMO level. And then we get to the light blue. This is kind of what's left over, if you will. If we do these 3 buckets very well, we should have dollars from every premium that we share back. And this is where we get into the sharing. So every partner that we work with, we do see them as an engaged risk partner, meaning that you have some upside risk as we all work together to improve the utilization, put in that primary care service, and then we're able to pay out those dollars that you can reinvest, that we can reinvest back in additional primary care services, additional supplemental benefits. And at the facility or community level, you can reinvest these however you need to. And we've had partners who have had some innovative ideas about how they can not just enhance services on campus for their plan members, but actually add in some things for all residents. Okay, so thank you very much for allowing me to walk through the model basics. I'm going to turn it over to Greg Bryant next, who will walk you through the plan specifics. Greg?
Thanks, Amy. Yeah, so we're going to talk about just some Michigan-based logistics. And touch. I know we've thrown a lot at you from a data standpoint, so going to kind of tie this together before we get into some Q&A. So, but as introductions from earlier, again, my name is Greg Bryant. I'm the Executive Director for Align Senior Care operating in Michigan. So we are, as previously stated, we're a Michigan-based HMO licensed through the state of Michigan Department of Insurance. We are also approved as a Medicare Advantage special needs plan. So that's the first thing I want to touch on. I know we've thrown a lot of acronyms at you. So again, just as you're familiar with Medicare Advantage plans, we are no different in that, obviously the beneficiaries have to be eligible, right? They have to have Part A and Part B. So it's Medicare Advantage business only, but a little bit different than what you're used to, where majority of the Medicare Advantage plans out there have been designed for community-based services. Mom and dad who live at home, our plan is designed for those beneficiaries who are basically residing in some type of facility, institution, HFA-based setting. So we'll talk a little bit about that. So under our special needs plan, basically, if you think about it, we've got easier to comprehend, but it's two benefit lines. One is an I-SNP, which is an institutional or institutional equivalent special needs plan. So that is a beneficiary who is residing in long-term care or residing in that AL, that assisted living, who qualifies as an institutional equivalent. I'm sure you're all familiar with the level of care assessment form through the state of Michigan, through their Medicaid. Basically, institutional equivalent is defined by, meeting the criteria on the set number of ADLs. So we utilize that form to assess a beneficiary as institutional equivalent. But again, this is for those residents or those living within the community requiring that nursing home level of care. So pretty straightforward. And that benefit line item is our institutional special needs plan. You recall the very nice graphic that Amy shared earlier that basically showed those benefits running left to right for the I-SNP. Our I-SNP, you may see the term Align Thrive. That is the name of that benefit plan within Align Senior Care. Our other benefit line, as also previously discussed, is a C-SNP, or a chronic special needs plan. And that's a dementia-focused plan. So typically this is, slated for those individuals obviously residing in a memory unit or, that HFA AL unit that have had a diagnosis of dementia. We know that's a very broad brush, but this is, as Will said and Amy touched on earlier, this is becoming a focus, as we look at the population and how it's aging. We have developed this chronic special needs plan. A little bit, there's some nuances, benefits across, both of these stay consistent. As Amy said, there is, an advanced nurse practitioner provided by the plan that rounds on both of these populations, based on, a risk-based acuity, whether it's weekly, biweekly, or monthly. Really, I think some of the key differences for the chronic to the I-SNP gets into kind of their financial obligation if they're in a private pay situation, a retirement situation. On the C-SNP, there are some differences, in their copay, coinsurance, and deductibles. But that's pretty much, aside from their resident location, that's pretty much the key differentiators between those two lines of business. As Steve said, working with Trinity Health Senior Communities, starting with them in 2018 and working into 2019. If you're familiar with Medicare Advantage, it's all about service area, which is a county within a state. So obviously we took a thoughtful approach in starting a new plan in the state of Michigan and looking at, where Trinity had sites, where there were facilities, basically where dynamics of population density were, as well as where, hospitals as preferred providers, which we'll touch on in a few minutes. So for 2020 and 2021, and again, when you start a new plan, there's that 2-year basically starting period. We went into 8 counties, basically the 5 on the east, which is obviously, think of it as Detroit proper and the Southeast Michigan area. And then, and moving from there to the west, with Washtenaw and Livingston and Ann Arbor. And then obviously on the west side with Kent County and the 2 counties just, due north and west there for Grand Rapids proper and some of those feeder communities. So we took a thoughtful approach on generating this list. Again, this is where we are live for 2020 and 2021. So obviously we are, as we said, looking for additional participants within this service area, for 2020, 2021. Another unique, because we are a special needs plan, one of the items that we haven't touched on is once our enrollment begins and opens, we can enroll year round. So I'm sure you're familiar with other Medicare Advantage plans that follow the annual enrollment period. While obviously we do follow the annual enrollment period, but we are not limited to that enrollment period. Medicare knows that under a special needs plan, situations change. These beneficiaries as an aged population, obviously, they have health issues. They need to move into a different living setting. So it's key to remember we are able to enroll year round. And I think that's one of the things that Steve mentioned for THSC as a good example. We started with enrolled members January 1st. We had obviously with the impact of COVID, obviously lost members, but we've reinitiated. We have reinitiated a phase 2 enrollment, if you will, as they're beginning to bring new admissions back into their facilities. Same way, if we add a new provider, a new participant as a facility, a SNF, a CCRC, once everything is, quote, implemented from a contract standpoint, obviously providers contracted, et cetera, there's some training and marketing, we could begin enrolling pretty much at will. And we've typically done this with other plans, same model, where from start to finish, we can have enrolled members within 60 days. And that's aggressive, I would say 90, but we have had, I would say very, we have very, very passionate participants who really want to make this happen. And so we've had great success in streamlining that implementation approach, where we can turn it on and in 60 days be live with members in a new facility. So that's something important to remember. I will touch on, Amy, if we could back up just one backup slide for this service area. As I said, 20 and 21, we are looking at expansion, obviously, for 2022. Now, interestingly enough, we will submit that list in February. If you think about the cycles for Medicare Advantage in those applications. So we are already looking at, where our growth potential is, where potential participants are. So we've got what I'll call a tentative list. some of the potential participants that we're talking to, that may have sites in Grand Rapids or Ann Arbor. Well, they've also got, have sites in Lansing as an example, and you can see where that's not in this list. So for 2022 or next February, we would apply for 2022 to add, as an example, maybe Saginaw. To cover those sites there. So that's really what we're looking on, is a very thoughtful approach, where the dynamics of the population are. And really it'll be for 2022, we'll add some number of counties just based on where we see participants, from a growth standpoint. And then from from 2022 and beyond, every year we would be able to add counties, based on potential participants. So thank you. So another dynamic around this obviously is because we are Medicare Advantage, we have to follow all the guidelines as it relates to a compliant Medicare Advantage network. Even though our beneficiaries, physically reside in these, life plan community, CCRC, standalone facilities, we still have to have the Medicare Advantage network as if they were living in the community. And so to have a compliant network, obviously, that includes your hospital network as well as a myriad of specialists that may potentially see your members enrolled within the plan. I'll say, for a special needs plan, it's kind of an interesting dynamic with this requirement. Unlike other Medicare Advantage plans, as a special needs plan, really we only utilize about 15% of that network, but that's still a requirement that CMS has mandated just in case. So we have to have a very broad network. And what this slide shows, we did in partnering with Trinity Health Senior Communities and Steve Kastner's group, we were also able to leverage, Trinity's family of hospitals as well. So we contracted with them across the states. That's obviously the Mercy Health and the St. Joseph Mercy Health systems across the state. This is where they're located. We leverage them as in network. Now there are other hospitals where we have facilities that Mercy or St. Joseph Mercy did not have a facility. So as an example, contracted with Tenet, Beaumont, Ascension, Henry Ford, McLaren, a few others. So obviously we don't want this to be by no means a limiting list, but just want everyone to know, as you're thinking about this as a possibility for your homes, what we have to consider as it relates to ability to service these members if they do have to go out. Obviously, I think as you've heard, it's our goal, to mitigate, the unnecessary or the unneeded hospitalizations, really keep them in their medical home. But when they do have to go out, we are able to leverage this type of quality out in the communities. So with that, I think we will open it up for questions. I believe I did see one question that came up. What would success look like in Michigan 2 years from now and then 5 years from now? So very, very good question. So I think for 2021, between now and 2021 and then the start of 2022, we want to be somewhere between, somewhere approaching, the 2,000 enrolled members mark, 1,500 to 2,000 enrolled members, across that spectrum of, as Amy said, whether they are standalone independent facilities, CCRCs that are utilizing, the full spectrum of care that, Amy went through earlier. So we've really got quite an opportunity. And if you think about, if you just simply think about the service area that I shared as the bulk of the population, with Southeast Michigan and West Michigan, that is the bulk of the population. I think off the top of my head, licensed beds, across that spectrum is somewhere in the neighborhood of 24,000 licensed beds. We know those are not all occupied at this point in time, but, for 2022, that's our goal to be somewhere between 1,500 and 2,000 lives. And then obviously beyond that, looking at the market in Michigan, really, as Will said, there's really no other, I would say, large special needs players there. We know there's some small ones that have 1 or 2 facilities, that are branched out from other states. So really our growth potential there from 22, in 22 and 23 is based on those counties. So at that point, obviously we want to see within 2 years, more than doubling of that number.
Yeah. Hey, Greg, thank you very much for answering that kind of from the Ally Align and Align Senior Care perspective. Steve, would you want to add anything about Trinity's goal as a participating provider, as an owner in the care model? What would be your goals for the plan and your residents 2 years and then maybe 5 years out?
Yeah, thank you, Amy. I think for us, it's obviously it's in alignment with what Greg said, but obviously get more of our residents enrolled into the program. We know that the benefits of the program are there, and if we get more of our residents involved and signed up and enrolled, we're gonna see better care overall for our residents, safer and better care for them. So I think it's for us, we're on the same page in terms of making sure that we get that enrollment up for the state as well as for our own communities, because it's the best model of care out there for our residents. We strongly believe that.
Great, thank you. Okay, we've thrown a lot of information at you. We've talked about the care model itself, how it can work in different living levels. We've talked about the plan. We've talked about how you can participate not just at the plan level, but also in the outcomes of the plan. Are there additional questions?
There are. I do want to say that you can add questions in the Q&A section of the webinar. We do have some right now, though, so we'll get into those. I know we're running a little short on time, and you've already answered some of the questions, actually, in your previous discussions. So, how are you determining who can enroll in the program, and who is the ideal enrollee?
Greg?
Oh, good question. So who can enroll in the program? Obviously, they have to reside in a participating facility. So a facility that has signed an agreement with Align Senior Care, but then they have to have Med A and Med B. So eligibility follows the guidelines just like any other Medicare Advantage plan. So they've got to have they've got to have Medicare A, Medicare B, and physically reside in a participating facility. So pretty straightforward approach.
Excellent. I don't see any other questions at this time, and we're actually only 2 minutes shy of total time. So I'll go ahead and wrap it up. Thank you, Steve, Greg, Amy, and Will. We appreciate the time you spent with us, and we know our members will benefit from the information you shared today. Thank you again.
Great, thank you.
Thank you.
Our pleasure. Thanks, everyone.
As we move into our next break, we'd like to thank our sponsor, Therapy Management, for sponsoring this year's Virtual Leadership Institute and the upcoming 5-minute break. As you grab your lunch, we would like to let you know that you can stay in this room to join us to learn with our sponsors during our virtual expo. Thank you, everyone.
disconnect.
All right. Can we should be good to go, I think. All right. Thank you very much, Brian. All right, here we go. Sorry for the little delay right there. Just had to figure out a couple things on our end, get everybody all set. So thank you. On behalf of Leading Age Michigan, we would like to welcome everyone to the 2020 Virtual Expo and Lunch and Learn. Everyone should have received, or at least all attendees should have received, a $15 Grubhub gift card this morning, I believe around 8:30 a.m. to your email. So go ahead and grab some lunch on us. We are excited to try this new virtual format and hope you are able to have some meaningful exchanges with our valuable business partners. My name is Blake Weller with Leading Age Michigan. I'll be your host during this fine virtual expo. We would like to say a special thank you to our expo sponsor, King Scott, as a silver sponsor this year. We will have a grand prize drawing at the end of the expo for basically for people who participate throughout the entire expo and then join our sponsors in their individual rooms once the expo is over. The winners will be contacted by Leading Age Michigan for information related to the delivery of their prizes. So make sure you go ahead and join all these sessions and all this virtual expo, and you'll have a chance to win, I believe, some Amazon gift cards. So always helpful. All right, so now we are running a little late, so let's go ahead and get things kicked off early and started. Our first organization presenting today will be our exclusive sponsor of the Leadership Institute, Omnicare. So I will now turn it over to Matt Garlick and let him take it away.
Thanks, Blake. Can you hear me okay?
I'm sorry, can you do that one more time?
Can you hear me okay?
Yep, sounds good.
Perfect. Good afternoon, everyone. As Blake said, my name is Matt Garlick. I work as the sales manager for Omnicare and CVS in Michigan. I've been with our company in various sales roles over the last 7 years and directly involved with Leading Age Michigan for the last 3.5. On behalf of Omnicare and the team that is with me today, we would like to thank Leading Age Michigan for allowing us to be involved with such a great organization and its members. While it's unfortunate that we weren't able to celebrate this event on the island or at the Grand Traverse Resort, we appreciate the opportunity to connect virtually and see so many familiar faces. Lastly, I do want to extend our gratitude to each of you for the care you are providing during such a tumultuous and unprecedented time in healthcare. It's all our pleasure to be your partner and a privilege to not only serve your communities and staff, but your residents as well. With me today, I've got a few other Omnicare team members. First off, Tom Katofias. Tom is one of our senior clinical managers. He currently resides in Brighton. He's been with the company since 1988, became a clinical manager overseeing the activities of our consultant pharmacists in Livonia initially, and then expanded to overseeing consultant pharmacists in all of Michigan and some of Northwest Ohio. Tom was promoted in 2018 to his current role. He helps support our clinical department internally. He also helps drive clinical and cost containment programs for our customers. A couple others that I have with me today, Gary Prezwara. Gary's been with the company for over 23 years. He lives in Dearborn. He's currently an account manager, but also former roles in operations as well as general manager of our Livonia pharmacy. Gary has over 10 years experience in account management, and he currently works with our senior living communities across Michigan. And lastly, joining us today from our team is Beth Courier. Beth is a senior director of account management. She is a pharmacist by background. She's been in long-term care since 1988 in various roles, consultant operations, a majority of her career in customer-facing roles, including direct involvement with Leading Age Michigan for several years. So just a quick video here to show, and then I'll turn it back over to Blake. Thanks, Blake.
All right, thank you very much to Matt and OmniCare. You can go ahead and join them in their own individual room once we have concluded the rest of the virtual expo, in case you have any questions or anything else you would like to follow up with them on. All right, so I guess next we'll move it on. We, like I said, we're running a little behind, so I guess we'll keep it moving here. All right, so next up we will have one of our gold sponsors, Value First, presenting here today. So it gives me the pleasure to turn it over to Trish Korsgren and Denise May. Thank you.
Thank you, Blake. Am I switched over?
Yep, you're all good. You can take it
Okay.
over.
Sure, thank you so much. I'm Trish Korsgren with Value First, and I just want to give you a little update about what our program is doing and some of the changes that we're going to be having at the end of the year. For those of you who don't know who we are and what we do, we're the group purchasing program that Leading Age National and 25 state affiliates own, including Leading Age Michigan. So our goal is to offer great prices to Leading Age members and generate revenue for the Leading Age owners. We have given millions of dollars back to Leading Age over the years in non-dues revenue. We started with this venture with our GPO partner MedAssets almost 9 years ago. And about 3 years ago, MedAssets was acquired by Vizient and Provista, so we partnered with them. Our agreement was set to be renewed at the end of 2020, and at this unprecedented time, Vizient and Provista have chosen not to renew our agreement. So, since we found that out, we have been hard at work finding new solutions to bring to the membership as of January 1st, 2021. We believe in the power that Leading Age members have in lowering prices in purchasing. We don't have a major announcement yet on the path that we're going to take, but we would like you to stop by our booth and make sure that you have all of the updated paperwork that we need to keep you on our roster in 2021. Many of you are part of more than one GPO, and that's just fine. You can be on the roster with us and other GPOs, but we want to make sure that you're with us in the future. So if you could click through to our booth either after this program or tomorrow, we will be happy to look up your community and make sure that you will be on our roster in 2021. And if you're not, we will get you over the paperwork you need to stay on our roster with us. So thank you for your support over the years, and we sure hope that we can continue to support Leading Age Michigan with our joint venture in the future. Thanks, Blake.
All right, thank you very much, Trish. And as Trish said, you can go ahead and find them once the virtual expo has concluded. You can go ahead and find them in their own room. And obviously, we will be having the e-social with all of our business partners tomorrow. And that will be a fun event. Everybody will be holding a nice networking or fun event in their room, so you can go ahead and join and hang out with the business partners, get a little bit more. All right, so next we will move on to Kingscott, the sponsor of the virtual expo and a silver sponsor this year. So now I will turn it over to Blair Phillips, Dan DeReamer, and David Martin from Kingscott. Thank you.
Thank you, Blake. This is David with Kingscott. I think we're going to start with a PowerPoint presentation here for you real quickly. Let's see if I can make this work. Optimize, share with some, share. Okay.
Hey, David.
Yeah.
Do you mind pausing it for a second?
I certainly can.
Did you click optimize for video?
I did.
See, I think that is the issue. So if you could unshare and then reshare and unclick the video, I think it will make it look better.
Very good.
If you go under slideshow, you can go to full screen. It'll show us just the slide. Yeah.
I'm going to restart from the beginning, I think, right?
Yep, there you go. That looks a lot better.
It's not progressing. There we go. All right, thank you very much. Oh, no, I got back to the PowerPoint. Geez, sorry about that. King Scott Associates, David Martin here. I'm a principal with the firm and the director of the senior living market sector. Would like to thank everyone for the opportunity to sponsor this greeting with everybody. And we support many associations and senior living partners across the state of Michigan and several other states as well. Just starting off, I'd like to thank all of you participants for being caregivers. I looked up a little quote, and in your eyes, or in our eyes, you're heroes, just like nurses, doctors, grocery store workers, senior living care partners are heroes as well. A little definition from Christopher Reeve of a hero. A hero is an extraordinary individual who finds strength to persevere and endure in spite of overwhelming obstacles. And we certainly have that in our society today with COVID and fires and floods, and I'm amazed to watch the news every day. So they asked me to speak just a little bit about King Scott, formed in 1929, which happened to be the same year as the Great Depression. So we are proud to still be here, having lived through that and several other things. 91 years in business of architecture, engineering, interior design, and civil engineering. I don't know, any of you that watched Mike's presentation, I loved his little story line of his life. And the one thing that stood out on that storyline that I saw that I could relate to was that he had twins right after he was married. And I have twins as well. They're 17-year-old. They're seniors in high school this year. And I feel very passionate for them about trying to make the best of their senior year that they can. But what caught my attention was Mike's comment on his storyline there about twins. Holy crap. And I had the same expression when I was at the ultrasound with my wife, and the nurse started the procedure and said, "Oh my goodness, there's two babies in there." And I just had to sit down. So I know exactly what Mike was thinking on that. Holy crap. Maybe you saw in the video about the locations of our firm. We have 4 locations across the Michigan. I was going to tell you that we've opened 35 offices since March of 2020. But those are really all our employees' households. We've sent everybody home with their equipment, and we've continued working on your senior living projects, and we're still here to help you. If you need our assistance in terms of looking at spatial separations and things like how do you adjust a dining room to be socially distant, we can help you with those kind of things. So again, very proud to be here. And at this time, I think I'll turn it over to Dan DeReamer, who's going to talk a little bit more about our senior living market. Or not.
I'm here.
Go ahead, Dan.
Okay. I just wanted to mention, again, reinforce what David said and thank all of the workers, everybody involved in senior care, and you are heroes, and we greatly appreciate it. I want to talk just a little bit about some of the different projects that we have. We've got all types of senior environments that we're working on right now. And one of the things we've recognized in working on all these types of projects is the importance of looking to the future and trying to solve a major problem that we're all going to have with the lack of units available for middle market. We think that's going to be one of the largest areas that we're going to focus on in the future. That middle market is very important and has really been underserved to date. We've all done the spa-like facilities, the golf course-like facilities, country club, but the middle market is underserved and needs to be approached. To that end, we've worked with a large general contractor to develop a prototype for the middle market and incorporate some of the things that we think are very important to that, to providing an affordable middle market product. We've looked at separating neighborhoods rather than separate wings that focus on a central core, separate neighborhoods. And that's one thing that we found out with COVID, which could be a very important part of the development of a project, that if we're able to separate neighborhoods, still have a central core, then we're able to maybe control a virus in the future. We are very passionate about trying to move forward with this middle market and would love the opportunity to work with all of you on developing an affordable, dynamic middle market product. And I thank you for viewing and good luck with the rest of your conference.
So just to close, I'd like to add 4 lessons I learned from caregiving. Lesson number 1, be grateful. Try and practice that every day. Number 2, never underestimate the value of positive thinking. I loved Mike's presentation, and we work a lot with our employees on that core beliefs of our firm. And that was a great presentation, Mike. Thank you for sharing that. Number 3, compassion makes you a better person. My kids would agree with that statement. And last, caregiving is rewarding. And I want to again thank all of you heroes for your efforts. We are here to serve you and help you. Please reach out to us at any time if we can be of assistance. Thank you.
All right, thank you to both David and Dan and King Scott for joining us here at the Virtual Expo today. Always good to see you guys again. All right, so next up, we actually have a new face to our sponsorship scene. I believe our first-time sponsor here. We have Acadia Pharmaceuticals, a bronze sponsor of the Leadership Institute. So I will now turn it over to Teresa and Sean. Thank you.
Yeah, thank you guys so much for having us. We're proud to be a part of the work that you all do. So Teresa and I, we cover Michigan, and I also cover Northern Indiana. So we are your representatives for the area, so we can help you beyond just this in-service today. So I'm here we're going to start out with a video but I'm here to represent Nuplazid, which is for Parkinson's disease psychosis, hallucinations and delusions associated with Parkinson's disease. So here's a brief video, and then we'll talk briefly about it.
Mike and I live in New York on Long Island. We met in 1979 at a mutual friend's retirement party. We've been married for 37 years. We have 11 children. Michael has 6 daughters. I have 5 children, 3 daughters and 2 sons. We have 27 grandchildren and 6 great-grandchildren. Before Mike retired, for 35 years, he was on the police department. And the end of his career, he was a homicide detective. I used to work in home care, and I retired from my position as a high school nurse. Mike was diagnosed with Parkinson's disease about 8 or 9 years ago. I noticed his gait seemed strange and that he wasn't swinging his arms when he was walking. And so I suggested we go to the doctor, and he suggested a neurologist. I didn't have much experience with Parkinson's disease, even with my nursing experience, and it frightened me. It frightened us. Last year, around this time, we were in Mexico. Mike went deep sea fishing with the couples that we went to Mexico with. And when he returned, by the way, with a big fish, I asked how it was, and he said, "It was great. I had a good time, but the ice was melting." One of the wives who was with us looked at me, I looked at her, and we laughed, and we said to him, "Stop fooling around." It took him a long time to believe me when I said, "We're in the Caribbean, there's no ice here." And I think he was embarrassed, I'm not sure, but everyone dropped the subject. And then it was over, and we didn't think that much about it. Actually, we forgot about it. There were many occasions where we would leave the house together, and he would say to me, "Are they coming with us?" And I would say, "Who?" "The children." "Mike, stop fooling around." "I'm not fooling around. They're sitting right over there on the couch." And I would look him right in the eye, sometimes put my hands on him and say, "Honey, we're alone. We live alone here. The children are all gone." The movement disorder symptoms, difficulty putting a jacket on or getting out of a chair, I can help Michael with. But when he started hallucinating, it's so scary because there's nothing I can do. I was really frustrated and upset, and sometimes we even argued about it. In my nursing experience, I'd never come across it, and it was something we had to talk to the doctor about. We have a good life. We've created a life before and after the Parkinson's disease. We're trying to continue doing that. We'll go sit in the car by the beach or walk at the beach, go to the movies, go out to our favorite Japanese or Thai restaurant. We do a lot of things. We do family activities. Keeping a positive attitude with this disease is probably the only way you can handle it. And what makes it easier is that Michael doesn't complain about anything. So how can I? Nobody really knows the day-to-day challenges, and they're extremely difficult, frightening, and in particular, the hallucinations were almost the scariest part because you don't know what's going to happen. We're sharing the story because maybe other people will understand that they have to bring this to the attention of their doctor. This is part of Parkinson's and that there's something you can do about it.
Great. So we want to show this video because it really highlights some of the devastation that can go along with Parkinson's. Parkinson's by itself is a devastating disease for some, and then when you add in the potential for psychosis and delusions, it just makes it even more difficult. Not only for the patients or the residents, but also for their caregivers, for the staff. It's just makes it very difficult. But Nuplazid, real quickly, is the only approved FDA treatment for Parkinson's disease psychosis. It's an antipsychotic, but it works differently than most of the other atypical antipsychotics. It really targets the 5-HT2 receptor, serotonin receptor, that we believe, scientists believe, is the area that is most responsible for psychosis in Parkinson's disease. So it targets that. It's been engineered for that purpose. So, and as a result, we have some really good societies that have recognized the value of Nuplazid. The American Geriatric Society, the 2000 Beers criteria, and the Movement Disorder Society all say that Nuplazid is clinically meaningful, clinically useful, and should be used in treating this condition. So, why is this important? All right, she brought that out in the video. I'm an LCSW by training. I've been administrator of home care agencies. I've also been a director of a large psychiatric hospital, Parkview Behavioral Health in Fort Wayne, Indiana. So I'm pretty well versed in mental health, and I know psychosis follows Parkinson's disease, but I didn't understand till I started working with the KDN, diving into this data, that 50% of the time residents will develop hallucinations and or delusions at some course in the disease process. So, and hallucinations and delusions just elevate the issues. So they increase the potential for falls, they increase the burden of care, they increase agitation, depression, they acting out, aggression, all those things can happen. As we know, we want, as providers, right, we want to keep them at, in the home or in home. When I was in home care, we wanted to keep them there, and the families wanted to keep them at home. But when we had unmanageable behaviors and hallucinations, that often caused us to have to put them at a higher level of care. Or nursing homes, when I was at the hospital, would often have to send us, and we had a 20-bed geriatric unit, would have to send us those residents that were struggling with hallucinations, and the staff just couldn't manage them anymore. So they'd send them to us for a few days to get them on medications to help, and then hopefully be able to send them back where they could be more manageable. So this is where Nuplazid fits in. So it can help with those issues and help keep them managed, help reduce the likelihood you'll have to send them out, keep them managed at the lower level, help reduce caregiver burden and so forth. It also, let's talk about hallucinations and delusions, because one of the things that will happen is it's not only 50% of the time they'll develop it, but most of the time, up to 90% of the time, the patients don't even talk about it. They don't recognize or not proactively saying, I'm experiencing hallucinations. In the video, I talked about him being potentially embarrassed. Well, we hear that a lot, or they know it's not right and they know it's weird, so they just refrain, they just withdraw. Or they might, if they're seeing snakes or bugs or things like that, that may make them really agitated. If they feel like their spouse is cheating on them, someone's stealing something from them, someone's talking about them, they're seeing animals running around their room. Those kind of things are very scary and can cause them to be, behave in erratic ways that are, put excess burden on staff and so forth. So Nuplazid will help diminish that, will help reduce caregiver burden, will help, potentially keep them at a lower level of care or stabilize in the level that they're at. So what we can do is we can help come into your facilities. We can help educate staff on questions. How do you draw out this information? How do you draw out what kind of questions can you ask the resident to help get them to speak about the potential hallucinations they may be, or delusions they may be experiencing. They may not be experiencing now, but maybe a month from now they will. So it's a continual evaluation of the resident to make sure that, it's not transitioning. And I also want to dispel one thing. Sometimes, because I have to be honest, I believe this myself, that there were sometimes benign hallucinations, and that, if someone's hallucinating and they're hearing music and they're following along or singing along, that's not harming anything. But in reality, this is a brain dysregulation, and it will likely get worse. So it's better to, when you recognize, even if it's benign and not causing any troubles now, it likely will later. So it's better to recognize it, to treat it, continue to be assessing for it, so that you can jump on it and prevent those unwanted behaviors and outbursts later on. So cost is something we often hear about. If you look at the cost in the Medicare D coverage, it's 100% covered on Medicare D. and 85% of the residents are going to pay $10 or less. So now in Part A, it's more challenging, but it's not impossible to get it covered even there. But even in the A part, we say let's do an evaluation. Let's use our NUPLAZID Connect, where we will help with prior authorization, we'll help with financial support, and we'll help connect the patient to samples if they need it or whatever. So utilize that resource, and remember that in the D space, it's 100% covered. So we will be available in chat rooms afterwards, so click on the Acadia, and we'll also be available tomorrow at Link to dive into things. We can talk about F-tags, we can talk about documentation tools to help. You know, I've been through surveys, I've been through Joint Commission, state surveys, so I know how painful those can be. So, but we can help with those kind of things as well. So thank you for having us. Thank you, Blake. I'll turn it back to you.
All right. Thank you both, Sean and Teresa, for that presentation. So I guess we're just going to move on right to the next one. So obviously you have seen this this company here a lot with us, and you will actually see her presenting later today. We will be turning it over to Therapy Management, a silver sponsor of the Leadership Institute. And the presenter from Therapy Management today will be Carrie Hensel. So let's turn it over to her.
Thank you, Blake. I'm going to share my screen. Oh, wait a second. I'm going to stop my share. Hold on. All right. How's that look, Blake?
It looks good.
Okay, great. So hi, everyone. Carrie Hensel here with Therapy Management. And thanks for having us, Leading Age. We love supporting you. As you can probably guess from our name, we are a contract rehab provider. We do subacute rehab, long-term care, outpatient therapy at senior communities across the state, including many Leading Age members. I'm going to talk with you for about maybe 4 minutes about how we achieve extraordinary results with our partners. I like to call that making diamonds. So as we've been hearing all morning and for many months, it's kind of an understatement to say that right now senior care teams are under intense pressure from every angle. No, pressure is not fun, but it's also not necessarily a bad thing. It can really push us to achieve extraordinary results. Like, after all, think about how diamonds are made. It's all about how we respond to that pressure. The teams who provide the best care and achieve the best results will be the ones who unify, who adapt and innovate together, and they see change as an impetus to improve. And as Blake mentioned, just side note, we're doing a talk today at 2:20 that is just on this topic of innovation. We talked with leaders across the state, and they provided us with many, many, many examples of innovation. We, like over 50 we'll provide today, starting at 2:20. And all thanks to the many leaders from Leading Age. Okay, so back to the topic at hand. How do we do that, achieve extraordinary results? As a therapy provider, how do we innovate and make diamonds with our customers? So I'm going to highlight 4 ways. One, we bring a creative, flexible, and innovative mindset and approach to our partnerships. For example, we use a leading edge technology. It's called VirtueSense, and you've maybe heard of it, and some of you, including many of our customers, are using it. It uses artificial intelligence and machine vision to predict and measure over time and reduce fall risk, and it's really cool, and residents love to use it. Another way we achieve extraordinary results is by fully integrating with your facilities care team. So our customers will tell you that we don't operate as a separate entity or hang out in our therapy silo. We are unified toward common goals, and we manage change together as a fully unified team. Our customers will also say that our pricing is very fair and transparent. So they clearly understand and anticipate their costs for PDPM, for Part B and such. And that full understanding of their costs puts them in a better financial position for the future. And finally, another way we achieve the extraordinary with our customers is by being actively present with them. We are based in Michigan. We live here. We work here. We are really active in our customers' communities. We're active, super active with Leading Age Michigan too. We provide tons of support and education. We attend our customers' events. They receive a huge heaping amount of attention and service from us. And for Leading Age members, we offer benefits because we are the chosen therapy provider in Leading Age's group purchasing organization. It's called the Business Alliance. So let me know if you want to know more about that. So it might be a bold question, but you guys know I'm a bold gal. Do you love your therapy provider? Yes, I said love, and we won't settle for less, and you shouldn't either. Our goal is always to build the strongest, most resilient relationships with our customers, and that kind of partnership is what enables us to turn pressures like COVID, like PDPM, and anything else the world can throw at us into extraordinary results. So if you want to talk about what a partnership like that might look and feel like for you and your organization, or you have any questions about therapy or changes proposed for Med B or anything else, I'm here. My contact info is there, and then I guess I'll go into my separate room. But thank you, Leading Age. Thank you, Blake.
All right. Thank you very much, Carrie. And as she said, you can see her at 220 in room 2 talking about innovations during COVID-19. So you feel free to join her there. And now last but certainly not least, we have another gold sponsor here and an organization you've definitely seen around us before, Ziglar. So I will now turn it over to Tom Myers and Jason Choi. Thank you.
Super, thanks Blake. I'm just refreshing screens here. This is Tom Myers. Hopefully everybody can hear me and see me okay. I'm joined today by Jason Choi, who's with us. So I want to thank all the Leading Age members, all of you who are taking care of our residents, our family, our friends, our neighbors, all of that, and taking care of them during these hard COVID times. And a shout out as well to your staff and everybody on those front lines. So very appreciative of all the work that all of you are doing. Ziglar's been a long time partner of Leading Age Michigan. And we wanted to just say a few words about Ziglar today. We're going to just, what are we doing here these days? And we're actually quite busy. In short, what do we do at Ziglar? You run your communities, we finance them. That's about the simplest way I can say it. We not only do senior living, as many of you know, we do hospitals. So Holland Hospital, Bronson are examples. We also get involved in something called corporate finance, and we have some private equity funds. Carrie, you just did a great tee up for us, and thank you for that. Virtue Sense, that's one of the companies that the Ziglar Linkage Longevity Fund has invested in. Some of you have considered funds in this investment, and we're happy to talk to you more about that offline. A third fund is going to be coming around. We've got 2 of these funds, but they invest in companies like Virtue Sense that companies like Therapy Management use then to help you enable seniors in their housing, et cetera. So I'm going to go ahead. Just many of you may know that Ziglar, and I'm wearing a conference shirt. It's a little hard to see the logo from a couple of years back. Ziglar hosts an annual conference, Strategy and Finance. There's about 700 attendees when we do them in person, CEOs, CFOs, board members, et cetera. Well, we're virtual this year as well, and it's just coming up here at the end of September, the week of the 23rd, so just right around the corner. It's virtual. There's no charge. You can have as many folks as you want join this, board members, CEOs, residents, I suppose, even, who are active and interested. So the registration for that is out. It's a heavy-duty educational time and opportunity, so keep that in mind. Jason, why don't you give us 3 of your best slides on what's going on in the fixed interest rate markets?
Sure. So thanks for that, Tom. So as a quick update on the capital markets then, starting with a little background, this chart shows 30-year history of the municipal market data, or MMD, which is a AAA benchmark index for taxes and bonds. So think of MMD as a tax-exempt equivalent of U.S. Treasuries for corporate taxable debt. You can see various spikes throughout this graph, but the key takeaway is that they are at all-time historic lows for MMD. Notice though, we did have a spike earlier this year due to COVID. Interest rates spiked and lenders stopped lending during the earlier stages of COVID uncertainty, but thankfully this was short-lived. We'll see the drivers for interest rate movement on the next slide. So this slide shows fund inflows in green above the line and outflows in red below the line. And these lines represent how people are utilizing their monies, their money into the municipal bond fund or tax-exempt health care funds with mutual funds such as Invesco, Vanguard, and Fidelity, to name a few. So when there are economic shocks, or in this case, a pandemic, people tend to get scared and pull money out of investments to have liquidity or cash. And this in turn shrinks the supply of capital, and therefore interest rates rise as people sell out of their bond funds. So I mentioned before, thankfully this did not last long, and you can see investors putting money back into bond funds, which is causing interest rates to come back down. And finally, this last slide, it's a pretty busy page, but what this page shows are credit spreads to the AAA MMD benchmark that I just briefly discussed, the AAA MMD being in the bottom blue line. So what this line shows is if you're a non-rated borrower, your cost of capital will be at the top blue line. If you're fortunate to have a BBB rating, your cost of capital will be around the purple line. So on this page, interest rates are a little higher than what they were pre-COVID, but as we saw earlier, interest rates are still at 30-year lows. So that's just a brief update on the capital markets.
Yep. So just jumping back up, we're at the bottom of the graph on interest rates. We had a wild ride with COVID, and which was short-lived, as Jason noted, and interest rates are coming back down. So what are folks like you doing? How are folks responding? Here's some folks across the country, Oregon, Connecticut, North Carolina, but then look at that, United Methodist Retirement Communities for their Porter Hills campus. And we know that there has been an affiliation with that organization about over a year ago. The joint entity was in the market last week, literally, as a BBB- rated credit. And, you know, just like your house, just like your communities, there's debt on them to finance that over 30 years. In this case, we financed roughly $50 million in bonds, and we had an average interest rate of just over 4%, 24 years. Phenomenal cost of capital at this point in time. We're going to go do an investor webinar in about an hour, and that will be for the Heritage of Kalamazoo, who has an expansion project that many of you may know about for Rebel Creek, and we're very excited about that. There's public information on that if you care to hear more about it. So our friends, you, others in Michigan are being very active. Ziegler is and has been a leader in the state of Michigan. This is a very long time period, 30 years. We looked at the data earlier. If you slice it pretty much any way, you know, we've been a leader through in the state through this period of time. I'm proud to say in my 24 plus years, which means I'm old, I've been serving Michigan the entire time at Ziegler, and I personally participate in many of these financings, which is very gratifying. You can see a number of our clients, and a number of you on the phone around the call today are our clients. And then last year, it was a busy year. Michigan, you guys it's something, you're very, very active right now. So United Methodist, a couple issues for Holland Home. We actually did some work with Heritage last year as well. So it's a very busy time right now in the capital markets, raising money for your debt capital for your communities in the state of Michigan. And then nationally, Ziegler, we're very active as well. So happy to interact with all of you. Jason and I might be running around. We're going to try to monitor the chat room afterwards as best we can. We'll be in the social tomorrow. Our colleague Pat Moran will be joining us. This afternoon, Jason and I, we're going to have to transition over to the Heritage webinar in just a few minutes. But thanks again, everybody. It's an honor, a pleasure serving you, working with you. We'd love to work with others. Well, Blake, back to you. Thank you.
All right. Thank you both, Tom and Jason and Ziegler, everybody there very much. So basically that will be the conclusion of the virtual expo portion. So we would like to thank all our sponsors for supporting the Leadership Institute and joining us today at the virtual expo. Now each sponsor will move into their own separate rooms in case you would like to follow up or have any additional questions or just want to even chat with them, hang out. To join these, you will need to leave this meeting, go back to the agenda. So actually right now, I'm going to go ahead and share my screen. Give me 1 second here. That way I can show everybody kind of what to do here. All right, so I believe everybody can see my screen. So you're going to go ahead and leave this meeting, and then you'll go back to the agenda here. You can scroll down until you see the Wednesday, September 9th. Obviously, you clicked on this virtual expo room 1 to get in. So you can just go right under there and you see Acadia, King Scott Therapy, Ziegler. You see all of them. You click in there and it will take you right into the room and you can go ahead and chat. And it looks like we actually have an email break right after that. So our next session doesn't meet until 1:15. So you can hang out there for 20 minutes or so until the next session starts and hang out, talk with them. And then once you're done with that, again, just leave and you can join either concurrent session, room 1 or room 2 at 1:15. So I believe that takes care of everything for the virtual expo. Again, thank you to all the sponsors and thank you to everyone for joining. And we will see you when we reconvene here in a few minutes. Thank you.
Thanks. We'll see you.
first, Michelle? All right. We're going to go ahead and get started. You'll probably recognize these two individuals already, but I'm going to go ahead and go through with the formal introduction first. Welcome back, everyone. And if you haven't done so, please make sure your first and last name appear correctly, as this is how our attendance is monitored and tracked for continuing education hours. My name is Dalton Herbal, and I'm with Leading Age Michigan, and it's my pleasure to introduce our next speakers. We are fortunate today as we have Larry Horvath, Director of the Bureau of Community and Health Systems, and Michelle Repke, Director, Federal Survey and Certification Division from the Michigan Department of Licensing and Regulatory Affairs. This bureau has regulatory oversight for state licensing of facilities, agencies, and programs in Michigan. In addition, the Bureau is the state agency on behalf of CMS for providers interested in being certified to participate in the Medicare and Medicaid programs. We appreciate that they have taken the time out of their busy schedules today to join us to deliver a general overview of what is currently happening within LARA and provide insight on where Michigan needs to go should a second wave of the pandemic occur, and also to review the enforcement of the governor's executive orders and infection control surveys. Please welcome Larry and Michelle. Hello, I see you're both muted right now.
Can you hear?
Oh, you just muted yourself again, somehow. Okay, there we go.
Okay. Is Michelle unmuted as well?
I should be.
Okay. First of all, thank you, Dalton, for the introduction and the work that Leading Age does. On behalf of the Bureau of Community and Health Systems, I do want to thank David Herbal and Laura Funch. We work closely with both of them. And I do want to recognize the hard work that Leading Age does in the state of Michigan. I've always said this about Leading Age, and I truly mean it. It is one of the best associations that we work with. They're very thoughtful. When they have concerns, they reach out. They're blunt with us when they do have their concerns, but they do it in such a professional manner that it fosters a good working relationship between Leading Age and the department. I know it's always hard as a regulatory environment to have that professional relationship at times with the regulators. There will be times where we disagree on our findings or our enforcement action. But I can assure you as a member of the association that both David and Laura and Dalton continuously reach out to us on your behalf to advocate for positions and concerns and do it in such a manner that really fosters a partnership with the department that I just want to just reaffirm that and speak highly of Leading Age. Very appreciative over the years working with this organization. We do this routinely in our stakeholders group when we meet quarterly, that we have these conversations, but also through calls and emails that David and Laura are not shy to reach out and talk with Michelle and myself and other members of our team. So on behalf of the Bureau, I also want to thank you as providers. I know as a regulatory agency, we're probably not the people that you want to see routinely, that there are always things that we may cite that you may disagree with. But overall, I think we all have that same purpose, which is delivering quality health care in Michigan. And so we understand you have a tough job. And we understand that the regulatory process sometimes seems a little draconian, seems inflexible, seems very prescriptive. And we do understand that, we recognize, and we try to work to the best of our abilities. There will be times that we do disagree, and we understand that. But I do want you to know, for you and your frontline staff, how much we appreciate what you do on a daily basis. And this was prior to COVID. And now with COVID, it is even 10 times more important what you do on a daily basis. And so we hope that sometimes you see us as a partner. We understand at times that you may disagree with us, and we understand that. Let me go a little bit over the department. So the department is the Department of Licensing Regulatory Affairs. And, you know, from healthcare, especially from the nursing home side, you will see inside the department, you'll probably deal with the Bureau of Fire Services at times. We act on their behalf, but the Bureau of Fire Services oversees the life safety code efforts in Michigan for health facilities. You might deal with the Bureau of Professional Licensing that oversees the individual licensing of nursing home administrators, physicians, social workers, nurses. And then there's us, and we're the Bureau of Community Health System, and we oversee the state licensing of nursing homes. And then we also oversee the federal certification. Unfortunately, we, like you, have been so busy that I do apologize that we weren't able to quickly put together a PowerPoint presentation for this. So unfortunately, you'll have to see my face, and I don't usually like to have my face showing. I'm not the most easy on the eyes or photogenic, so I sure wish I had a PowerPoint presentation up for you. But unfortunately, we've just been so swamped like you. But I am happy to have joining me, Michelle Rupke, and Michelle oversees the federal certification side, and I'm going to have Michelle speak on some issues. But just inside the Bureau, we do state licensing, and I'm going to talk a little bit more about state licensing at the end of the presentation. And state licensing, you always have to understand, is a requirement. To operate a nursing home in the state of Michigan, you must have a license. And always keep in mind the definition for a nursing home in the state of Michigan is 7 beds or more, or serving 7 individuals or more with 24/7 continuous medical and nursing care services. So a state license is required, and that's what we oversee. So we oversee that part where we give you the initial license, and then the renewal of that license, and then do the routine inspections and investigations as required by state law under the Public Health Code. So, you know, the Public Health Code is what we operate under for state licensing, and that's Article 17 of the Public Health Code. And particularly for nursing homes is our Part 217 of for nursing homes and state licensing. Unlike state licensing, which is a must, federal certification is a voluntary action. And that's where you want to participate in the Medicare and Medicaid programs. The majority of Michigan nursing homes are also federally certified, although it's not a requirement. But the majority of homes are certified. We do have some homes that are either dually licensed because they're also a hospice resident in a nursing home, so that we have that facet. And we do have some homes that are strictly third-party pay. But the majority of our homes are federally certified. And probably of all areas that you will deal with in our Bureau is the federal certification portion. It's going to be Michelle's division and her teams that you will pretty much deal with for the most part. On the state licensing side, you won't see our people as much, but on the federal certification side, that's where you'll see our staff out there acting on behalf of the Centers for Medicare and Medicaid Services. And on the federal certification side, I just want to emphasize a few things before Michelle kind of talks about some items that we want to bring to your attention. But on the federal certification side, always keep in mind that we act on behalf of CMS, that ultimately the final decisions are made by CMS, that we follow the state operations manual. Now that sounds like it might be a document that we put together, but the state operations manual is a federal document that all states operate under. So we should have consistency when we do certification in all 50 states. And then we also have what we call a mission and priority document. And that mission and priority document is basically CMS telling us what activities we should be doing. And historically, it's been pretty routine with initial certification visits, then recertification visits, and then investigations when needed. And we default primarily when we have a complaint, we default first on our federal authority to do our complaint investigations. So that's the general overview of the federal process. We have approximately probably about 80 to 100 inspectors, even though we're down right now in the number of inspectors we have. As much as we are down in inspectors, Michelle's team is keeping up with the workload and scrambling like I think everybody else is scrambling. And so I asked Michelle to join me because Michelle's more the expert. And we're going to kind of go over a little bit about some insights on the infection control survey process and the schedules. Michelle's also going to talk to you about the recertification and revisit schedules that we're starting back up, and talk about some items of enforcement with directive plans of correction. Then I'll come back and talk briefly on state licensing, and then we would like to open that up for questions and answers. So I appreciate Michelle joining me, and I'll let her talk about the federal certification process.
Thank you, Larry, and good afternoon, everyone. I also want to reiterate what Larry said. I know for a fact you are all busy, and we really, truly appreciate what you do for the residents in the state of Michigan. You have a very tough job, even when there is no COVID, and now that you have COVID in the working, it's even making it more difficult. But again, I want to say thank you on behalf of myself and my teams for what you do every day. One thing I want to talk about is the infection control surveys and the schedule. This is something that CMS has started. It's those infection control surveys, and we get the schedule. It's pretty, right up front. We get the schedule on a Friday afternoon. We have to have them started within 3 to 5 days. So I send it out to the managers, and we have 3 to 5 days to figure out how we're going to survey those facilities listed on the list for their infection control surveys. It's not planned out. We get a notice. It's all short notice. So if you had one done 3 weeks ago and they show up on the list again, we have to do it. CMS gives us a 2-week reprieve, but if they've been done 3-4 weeks ago, and they show up on the list again, we have to do it. This has all been directed by CMS, so we have to do it. Just recently, the QSO memo 2038-NH. I highly recommend that all of you take a moment to review this document. They have made some changes to the infection control survey process, and also they have added some new tags, new deficiency tags. And a couple of things I want to bring just to your attention is talks about testing. It talks about the infection preventionist, and it also talks highly about documenting. If you look on page 10 of this document, whenever you have a chance, surveying for compliance, it's telling you what our surveyors are going to be looking for when we do come on site for these infection control focused surveys. And the highlight of this whole document is actual documentation. If you are finding you cannot get your test results within the 48 hours, you need to document and have documentation to show us and the surveyors of every step you took to try to make sure that you could get your testing results within 48 hours. If it was contacting your health department on this day, if it was trying to reach out to another laboratory on this day, you need to keep track of all those phone calls, all that documentation to show that you are making a conscious effort to ensure that your testing results are done within 48 hours. Another thing is that infection preventionist. With this new survey or this new QSO document, we also have a new COVID-19 focused survey for nursing homes, a new checklist that came out. All these are public documents, so you know exactly what our surveyors are going to look at when they come on site. And this new document is approximately, let's see here, it's approximately 11 pages, but it has a lot of red ink, and the red ink is the new portions that the CMS has just added because they have those new tags. The one is for the F882, you have F884 and F886. These are all new. They have to deal with testing. They deal with infection prevention, all of those. So I highly recommend that you take a minute and look at this. This is very important. It's what we're going to be looking at when we do our infection control surveys. So you can get a jump on it, go through the checklist yourself, have everything ready for when our surveyors come on site. But I really do highly recommend you document. You got to document everything, and that's what our surveyors are going to be looking for. Moving on, the one thing I do want to add with this testing, all of you should have, or you are in the process of getting your CLIA certificates. You're going to need to have this CLIA certificate in order to do the rapid testing that President Trump is sending out to all of the facilities. If you don't have a CLIA certificate, you can get with our CLIA section. You can go onto our webpage and there's a link. You can go to michigan.gov/CLIA and it will tell you how to apply for a new CLIA certificate. If you have one, that's great, because one thing our surveyors are going to ask when we come on site, they're going to ask to see that CLIA certificate. So please apply, because you need a CLIA certificate to do those tests. If you have one, make sure that it's visible or be able to show our surveyors when they come on site for this CLIA certificate. And if you can't find it, you can always call the CLIA section directly at 517-241-2648. And you can speak to a CLIA representative and ask for a letter showing that you do have a CLIA certificate. We do not reissue them. What we do is we reissue a letter to show you that, or to demonstrate that you do have the CLIA certificate. It is valid in place of your CLIA certificate. And you either have the CLIA certificate or the letter, you're golden, and that's what our surveyors are going to be asking for. Again, that's michigan.gov/CLIA. It talks about how to get your CLIA application and how to apply. It also has the contact information of what you should do to get your CLIA certificate. Revisit schedule and recertifications. With the new QSO 2035, that is opening us up to start doing some annual recertification surveys. We're doing revisits. We had that suspension of revisits with that QSO 2020. And as of June 1st and after, we are now starting to go back and resume normal enforcement, normal recertification surveys, and that includes revisits. As always, we are trying to do desk revisits whenever possible. So if and you'll get a notice in your notice that accompanies your 2567, it will tell you if you're eligible for a desk revisit, and it will tell you what you need to include to the manager for that desk revisit. The research, we are starting, but we're starting slow, because remember, CMS has that list of infection control surveys that comes out on a Friday. We have to start doing those on Monday. So we have no idea from 1 week to the next how many Michigan facilities are going to be on the list. And it makes it pretty difficult for us to schedule our research. But we are starting to do the recertification surveys. We do have some humps we have to get over, because we're used to our survey process. We're used to going in and talking with every resident. We still have to do that, but we also still have to figure out how to spend time with a resident that's in the COVID wing of your facility that maybe does have COVID. We have to spend some time with them, interviewing them. So that's causing us some discussion on how we're going to approach this, but we are starting to do the recertification surveys. So just be aware that that's happening too. Enforcement and directed plans of correction. For CMS came out with a directive that if you are cited F880, you are required to do a directed plan of correction. The directed plan of correction is, we are essentially telling you what your plan of correction is going to be. We have gotten new clarification within the last couple of days from CMS on how we need to approach this directed plan of correction. It's not all copy and paste, everybody gets the same one, which we thought it was because of the earlier direction, but now we have to tailor or customize each directed plan of correction per your citations. So with that said, it's very, very important that you look at the notice that accompanies your CMS 2567. In the notice, it will have your directed plan of correction that you have to do for that particular survey for those deficient practices that were identified. You need to take that plan of correction or that directed plan of correction. All you have to do is copy it out of your notice and paste it under the F880 as your plan of correction. That's all you have to do at that point, and then submit your plan of correction along with your other POCs for your other deficiencies, if there are any, and send it into your survey team manager using the ePOC system. So if you have 4 citations, maybe a F689, an F600, and an F880, you have to come up with your plans of correction for the F600 and for the F689. But we are telling you in your notice what your plan of correction is going to be for the F880. So like I said earlier, whatever we tell you in your notice for your directed plan of correction, all you have to do is copy and paste it right to the ePOC for your plan of correction for that tag. We are telling you that's all you have to do. Then you have to perform those items that are in the directed plan of correction. I hope it's confusing. I know we haven't really done this in Michigan because it is a lot of work, but we have to with the directive from CMS. The best advice I can give you is follow your notice that comes with the 2567, and you're going to have to do what your directed plan of correction tells you you're going to have to do. And with that, I'm turning that back over to Larry in state licensing.
Michelle, we did have a question during your presentation. And the question is if I'm in an assisted living facility, which is in the state of Michigan, I'll talk a little bit more about that, not licensed. And you were talking about nursing homes with point of care testing and the requirement to have CLIA. But I might be doing some testing inside an assisted living. So can you explain just CLIA in general, when you need a CLIA certificate, no matter if it's a nursing home, a homes for the aged, or assisted living?
Sure. I'll put my CLIA hat on. And once upon a time, I was a CLIA surveyor for the state of Michigan. CLIA certificates, it's a federal program, and anybody that does a test, whether it's a finger stick glucose, whether it's a urine dipstick, if you do any testing, whether you bill or not, you are required to have a federal CLIA certificate. Doesn't matter what type of facility you are. So many people think I'm not a lab, but the one question I always ask, do you do one finger glucose a year? They say, yeah, we do glucoses on our residents. You are a lab. You would have to have a CLIA certificate. People ask, I don't get, oh, I'm not gonna bill for this. It doesn't matter. If you do any laboratory testing at all, you are required to have the federal CLIA certificate. And again, you can go on to michigan.gov/CLIA, and you can go on to that webpage, and it has instructions on how to apply for a CLIA certificate if you do not have one. But you need to have one, it's a must.
And Michelle, could you, I might just, I think we got another question there about CLIA. Let me see if I can pull it up. Can you talk a little bit about like the difference between, a simple point of care testing and the difference between a certificate of waiver and maybe a different type? When do I decide that I need a different level of certification?
Okay. CLIA has 4 levels of certification. They have the CLIA certificate of waiver, the provider performed microscopy, they have the certificate of compliance, and a certificate of accreditations. So there are 4 different types of CLIA certificates you can have. What has happened is the FDA takes every laboratory test and they evaluate it, and they put it into one of 3 categories. They put it as a waived, moderately complex, or highly complex. For a wave test, the FDA has deemed that if somebody did the test incorrectly, that there's going to be other factors that are going to get involved, and that person is not going to die immediately. For example, say somebody did your finger stick glucose incorrectly. That resident or that patient is going to start to show other signs and symptoms that will lead them to go into the emergency room or lead them to have another test done. That way you can catch that error that was made. So they feel that those wave tests or those tests that somebody's not immediately going to die, they're kind of almost, I want to say, goof proof, but you have the regulations are such that you just have to follow the manufacturer's instructions. The moderately complex and highly complex, those are involving where you have to have training and education to do the test. An example of a moderately complex test is when you maybe do a CBC. You collect the sample, you put the tube up to the instrument, hit the go button, it sucks up the sample and it prints out results. So you have to be trained how to use the instrument, and you have to have some training to look at the results, but the instruments are such that they flag if the result's high or low. So that way you can take it to somebody that's the doctor or somebody that's more educated than yourself, and they can help interpret those results. A highly complex test is where you yourself, like myself as a medical technologist, you actually make the diagnosis or you make the decision on what the test result is. A good example is like myself, when I used to work in the blood bank at the hospital, I would cross match a unit of blood and I would have to look underneath the microscope and look at the red blood cells from the donor unit and the red blood cells of the patient and see if they're clumping together or not. So I made that decision on if that blood is compatible or not. So I, as an individual, makes the decision. Another one is like a pathologist looking at a skin slide and making the determination if that's a cancer cell or is it just a normal cell. So that's the differences between. So if you, and all package inserts, if you're looking at your test, looking at this test kit, look at the manufacturer's package insert. It will clearly state somewhere on there if it's CLIA waived or if it's moderately complex. A lot of them, some of them could be the same. CLIA waived, you have to follow the instructions. If it says I need a nasopharyngeal swab for a CLIA wave test versus I need a serum for the moderately complex test, you need to follow the manufacturer's instructions and use the nasopharyngeal because I have a CLIA certificate of waiver. If I had the moderately complex, then I can just go ahead and use the serum sample.
And Michelle, just to clarify for everybody, if you're drawing a specimen and sending that specimen off to the lab, that really does not require a CLIA certificate because you're not actually doing the diagnostic testing there. You're really just collecting the specimen. So that would not require CLIA, correct?
Correct. Actual collecting the sample, that's not CLIA. CLIA is actually performing the physical test. You are physically taking the dipstick and putting it in the urine, or you're physically poking the person and adding the drop of blood onto the glucose strip. That's actually performing the test. So if you are actually just collecting it, CBCs, a lot of nursing homes, you might have your staff collect a blood sample or collect a blood glucose and you're sending it to the lab. That does not require a CLIA certificate. It's only when you actually do the test that you need to do the CLIA.
And Michelle, I might not be as versed on this, so I might get the question wrong, but if I'm a Homes for the Aged, does the CLIA certificate require a physician signature, or I mean the CLIA application require a physician signature? And if I'm a Homes for the Aged, if I don't have a physician, how do I deal with that?
For a CLIA certificate of waiver, there are no regulatory requirements on who can be the laboratory director or who has to sign for the physician order. All that's required for a CLIA certificate as a waiver is you have the manufacturer's package insert and that you follow it. Or if you want to get a CLIA certificate of waiver, anybody can be the director. It can be Joe Schmo. Larry could be the director for a CLIA certificate of waiver with no medical background at all. The CLIA doesn't specify that who can be the lab director for the waiver. As far as ordering the test, in Michigan, it was determined, and it's in the public health code, that if it's a CLIA waived test, and the manufacturer says it's CLIA waived, you do not need a physician's order to perform that test. So in other words, Larry, if he's got a sore throat, he could go to the Meyer Pharmacy and ask to have a strep test done. There was no physician's order required, and he could have that test done at his request. So for a certificate of waiver, you don't need a laboratory. Your director just has to be anybody, maybe the owner of the adult foster care home, maybe they would be the actual director. But always remember, if you're signing a document that you're going to be the laboratory director for that CLIA certificate of waiver, you then take responsibility for the testing that's being performed. So everything, if there's any enforcement with CLIA, it always goes back to the laboratory director. So always keep in mind, if you're signing your name that you're the laboratory director, you have to take responsibility. In the nursing homes, a lot of the nursing home administrators I see are usually the laboratory director or the director of nursing. So those are just the types of things.
Thank you, Michelle. So I'm going to kind of just update a little bit on what's going on in state licensing, and then we'll open it up for more questions and answers. So one, for the most part, we talked specifically about nursing homes. And for nursing homes, primarily you're going to deal with Michelle and her team because of the prescriptive nature of the CMS process. In state licensing, we oversee state licensings for homes for the aged, adult foster care, and nursing homes. And just to kind of keep in mind, in an adult foster care home is serving individuals with physical, mental, or aged, physical or mental disabilities, or an aged population, and that home is 20 or less. For homes for the aged, it's 20 or more, primarily serving the aged population. And if it's connected physically to a nursing home, it could be less than 20. But for the most part, homes for the aged are 20 or more, serving an aged population, and adult foster care is serving a mixed population. Our state licensing process has not changed on those. We continue to do our routine process for initial licensure and renewals. We are looking a little closer on infection control prevention and how you're doing that in your setting, but it's not as prescriptive as you will see in the nursing home side. So we are trying to gear our staff. On the nursing home side, our staff is more medically trained. On the adult foster care and homes for the aged, our staff are more social workers. So they're going to kind of look for just cursory items on how you're dealing with infections, how you're dealing with masks, how you're dealing with hand sanitizing, and so on. On the state licensing side, we kind of really, we know that you guys had a lot going on with just COVID in general. And the robust nature of the CMS process, that we kind of scaled back on the state licensing side. But there was a little bit of an initiative to actually have us come.
I think Larry's
provide
froze.
consultation.
Oh, Larry, you froze.
The federal. Oh, okay. On the federal side, we don't provide consultation. On the state licensing, we're going to be providing consultation with these new teams that we're developing. And we hope to develop 2 teams. And what we're going to focus on are homes that are hubs, homes that are having high rates of citations from the federal team, and those that actually are not federally certified. So our number one priority is those homes that are not federally certified. We want to get out and do more infection prevention and control inspections in those that are licensed only. And this is only on the nursing home side. Then we will start to focus on hubs as well as those nursing homes in our 8 regions that are identified as high risk because of the number of citations that they're receiving on the federal side. We want this to be more consultative. We don't see this as a where we're going to go in and cite. Obviously, if we have numerous violations that are egregious and not getting corrected, we still have the authority to cite and take state licensing action. But this really is to kind of work and say, how can we help you improve your prevention and control efforts in the home and provide a little bit of consultation. So that's what this team's going to be about. We're in the process of hiring the remaining staff for this unit. We have 2 lead people that are going to act as our lead. And then we'll have 2 small teams that will go out and start to do these initiatives. So you will see state licensing a little bit more, but it will be more in a consultative approach. In addition with this effort, we're going to try to work with DHHS and their IPRAT teams because they're doing some assistance with consultation through telephone contact with you. But we want to work closer with IPRAT to make sure we get a consistent message between DHHS and LoRa, because we know you as providers are struggling to keep up with CMS guidance, with CDC guidance, with DHHS guidance, and with our guidance as well. So we're going to work closer with DHHS, and we've been working on that over the last couple of weeks to make sure that we can have a consistent message of what the expectations are. And part of this came from David's request. He sent us an email concerned about the lack of a consistent message across the state between the various departments and federal government. So we have been working closely over the last week to try to put together more guidance on this, and I'm going to talk about it just briefly. As far as enforcement of the executive orders, executive directives, or the epidemic orders, we're really going to handle that from a state licensing side. So if our federal team's out there and they see that there's a potential violation of an executive order, they're going to make a referral inside the Bureau, and then the Bureau will take a second process to look at any potential violations of executive orders. So we really don't want to handle the executive order. We want to keep the federal side completely focused on the federal side. So we will have a different process. We're working on what that process will be. I can kind of give you our initial thought is if we feel that there's a violation of an executive order, our initial action is to contact the provider, be it a home for the aged, adult foster care, or a nursing home, to contact them and let them know, hey, we believe there might be a lack of enforcement in the mask order, or of something of that nature, or visitations. And so we'll give you an opportunity verbally to kind of give us an update, as well as hopefully implement any corrections as we provide you guidance. If we see continued allegations or observations that executive orders are violated, then obviously we'll work closer with DHHS and the Attorney General's office to see what enforcement action we should be taking on the executive orders. So that kind of gives you a sense that we're really keeping the federal team out of the executive orders, but we have already done a couple of investigations on violations of executive orders. The good news is the allegations couldn't be substantiated because you have to understand the executive orders and the medical conditions of individuals that might not be wearing a mask. So they might be one of those few that can be have an exception. So so far to date, we've been very fortunate that the providers we have conducted an investigation on have been compliant. I do want to do a quick update on nurse aides because I know frontline staff is important to delivering care. And as you know, during the executive orders, we had some exceptions to where you could use additional staff. Now we're getting back to primarily using certified nurse aides. So from the nurse aide side, we've done, since we've restarted testing, we've done over 1,800 examinations for nurse aides since July. We still have about just under 800 candidates that have completed their classes and waiting for testing, so we are still working through that. We have about 241 new candidates since August 1st. So you can see that we are still working through the backlog on testing for nurse aides. One of the biggest problems we faced is, as you see schools closed, community colleges closed, what we've struggled with in our testing sites is to get testing sites reopened. And when we do get testing sites reopened in a community college, there may be limitations to how many we can bring into that testing site. I will say, just to give you some data, prior to COVID, we had about just over 50,000 certified nurse aides in our registry. Since COVID, we have now about 45,000 nurse aides in our registry. So you can see that we did see a significant decline during this period in the number of certified nurse aides that we have in the state. A few things that I'm going to have, Michelle, I want to talk to you just briefly about some of the things that we're working on, and this was actually spurred by one of David's email from Leading Age. And so we're kind of working on guidance with DHHS between our federal team, our state licensing team, and the epidemiologists over at DHHS to make sure that we're consistent with CDC guidance and to make sure that we're consistent with CMS guidance, and that both state licensing and the federal teams are working from that same understanding. So what we're looking at is how do we handle a resident that is COVID positive? How do we handle a resident with a known exposure that occurred outside the facility? So they could have been exposed while they're outside the facility and you know it. How do you deal with a resident that has an exposure inside the facility from another resident or a healthcare professional? And then how do you deal with an individual who is a newly admitted or readmitted to the facility whose COVID status is unknown? How do you deal with a resident who's not a new admission or readmission, but who frequently leaves the facility for medical reasons such as dialysis? And then how do you deal with a resident that's not a new admission or readmission, but who may need to leave the facility occasionally for medical reasons? So those are the scenarios that we've been putting together over the last couple of weeks to kind of get you guys some specific guidance on what we would have as our expectations when we go out into the field. The other thing that we want to focus on is the source control measure, and that's the residents wearing the facial coverings. We do recognize that some residents cannot wear facial coverings because they have a medical condition. And we do want to stress that not all residents need to wear a mask when they're in a communal setting, but we need to know why they're not wearing a mask. And so there should be some documentation on that. So we will be talking about that as well in our guidance. The last thing that I want to kind of touch upon as we kind of close and open it up for questions is, and I'd like Michelle to join me on some simple things that we've been noticing while we're out there. When you're doing infection control, and most of you, this will be just simple and common sense stuff, but we continue to see this out there. When you're using cleaning solutions, make sure that you have identified a cleaning solution that is acceptable, such as by the EPA for disinfectant related to this virus or any other potential pathogen. So the staff should understand what cleaning solution they're using. In addition, they should understand, like, what is the contact time? Do I spray the equipment down? So let's say I'm in a physical therapy. I just got done with physical therapy with a resident and they leave. Now I clean the equipment down. It's our expectation that the therapist who's cleaning the equipment down should understand what chemical they are using and what is the contact time. Do I spray it down and wipe it immediately off? And if it says that you leave it on till dry, we're going to be looking at the instructions on the bottle, and we would hope that your staff is looking at as well. That's going to eliminate a lot of citations that we're seeing out there, because we see staff not reading the instructions on the bottle, and they'll say, well, I'll spray the equipment down and then I'll just wipe it off. And then we'll point to the bottle that says this has to have until it dries, or it has to be there for 3 minutes. So just like what Michelle said on CLIA, read the manufacturer instructions on these chemicals and make sure that the chemicals are being used in the proper setting. The other thing is, look at your physical plant area and think about your physical plant area and your limitations. So if you had a therapy room at the end of a hallway, we would hope that you would not make your observation area in that hallway, in which probably residents that are at no risk for COVID, they're basically on the clean side, that they're not traveling for some reason through that hallway, your observation hallway. So look at how you lay out your isolation areas, your observation areas, to make sure that residents and staff don't need to travel through those areas unnecessarily. Make sure that staff understand that the clean areas, you know, when they leave a dirty area or a clean area or a dirty room, or, you know, entering through the clean area, how are they donning and doffing their equipment? You know, the majority of the things that we're citing are not rocket science. The majority of the things that we're citing are just common sense things that people struggle with because they're so busy delivering care that they forget. So Michelle, did you want to add a few observations that you might want to speak on as far as infection control?
Just like you said, the donning and doffing, you need to make sure a resident, if they're on transmission-based precautions, make sure there's signage on the door, so if somebody goes into the room, they actually know what the precautions are, what needs to be done. We have the donning and doffing, like Larry said, and just think of things like the food cart. Coming from the kitchen, you're bringing a food cart, it's coming down the hallway, you're in a COVID positive wing, you have that food cart, that individual, the dietary person, is going to be taking those food trays in and out of different rooms. They need to be changing. There's all of that infection control things you have to do, changing gloves, changing gowns. They're going from one room to another. And then you have this cart that's been handled, that's been in this area. How are you going to disinfect it? So those are things that you really have to think about. Again, we have to stress following the instructions and the time that the disinfectant has to be on the surface. That's huge. Screening when they come in, you have to really screen the residents. You've got to screen your staff. You've got to show that they are, how they answered the questions, what their temperatures were. Screening is very important. So those are some big things that we're still seeing. The donning and the doffing, that is huge. Hand hygiene, not wearing the PPE, that is still, we're still seeing that, and so it's still very quite prevalent.
I think some of the other things that we have observed is equipment will not be clearly identified if it's dirty or if it's clean. So clearly identifying that equipment to make sure that the staff understands that this is the clean equipment that you can use. As Michelle said, a lot of the screening questions we have seen, the screening questions are not robust. They're missing a lot of elements of the signs and symptoms for COVID. In addition, you know, you really need to take a look at your policies and procedures, because even though you may go above and beyond the CDC recommendations, if you decide to do that and you put it in your policy and procedure that you're going to take an objective temperature, then it's our expectation that you're following that procedure. If you're going to take a subjective temperature, you know, we want to see that stated in there, but we clearly want you to refresh your policy and procedures, educate your staff on that, quiz your staff, because that's what's going to happen is we are going to ask the staff in the hallway, and it's going to seem like a casual conversation. But they really have to understand why we're asking that question. And it really is to say, do they really understand when we ask that question about what is the contact time after you clean something? Do they understand that we're really looking for a specific answer, and that specific answer is going to go to what the manufacturer guidance is? Are the screening questions appropriate when you're screening inside the facility? So hopefully we have given you some insight of things that are coming down the road. We've given you some insights to improve your compliance. We would love, I know Michelle would love to have every home compliant. Our job doesn't become easier when we find citations. I know that I know at times it is very frustrating because it seems like it's a simple citation that we should just kind of overlook. And it's, you know, maybe a lapse in judgment by one staff. I understand that. But, you know, we have to cite because that is what CMS requires us to do. So we got about, sure,
I want to add one thing. One thing that I would highly like to recommend is that as you know, when we're on survey, observation is the most, we have observation, interview, and record review, and our observations are the strongest. You might just see our staff, just sit there and watch. You can do the same thing when we're not there, just, you know, non-survey time. Just sit someplace in your facility and just watch. And you can see if people are donning or doffing correctly, and just the things you're going to observe, you'll be amazed. And that's just one good tool. Just observe your staff. Walk up and down the halls, watch them, see if how they do things. That is the most important thing that I would highly recommend that you do. Just watch. You'll be amazed at what you see.
So we got about 5 minutes left. We'll open it up to any questions.
Excellent. Just a reminder, if you could please add your questions to either the question and answers section or the chat section. We'll go ahead and read them out. I know Larry and Michelle have been monitoring this as we go through, so they'll see it pretty quickly here.
And I do want to emphasize, Dalton, that we hope to get that guidance to you guys pretty quick that we've been talking about, that David asked us to kind of put together. I thought that was a great suggestion. We hope to get that to you soon so you can share with your members here. And I think that will get us all on the same page.
Thank you. All right.
I am not seeing any questions.
No, I'm not. You actually were answering them as we went through, so I don't see any right now.
If at any time somebody has questions, they can just reach out. If you want to, Dalton, just compile them and send them to Larry and I. We can answer them.
Yeah, that'd be great. We'll plan on doing that. With that, we'll move to close. I'd certainly like to thank both Michelle and Larry for their time today. We really appreciate the relationship we have with both of you, and we hope to continue doing great work for Michigan seniors together.
Well, thanks for the invitation.
Yes, thank you.
No problem. All right. Moving forward, if you would like to, once again, thank you, Larry and Michelle. We're grateful for the time you spent with us today, and the information you shared was very informative and will help our members to stay in compliance. If you'd like to attend the...
I did see a question come up, Dalton. I don't know.
Oh, go ahead.
So guidance currently says that physician orders are required for point of care testing in a nursing home. QSO 38. Michelle?
That's the general consensus is for CLIA, but Michigan has adopted the direct access testing, which does not require a physician's order for a CLIA wave test. If you are collecting a sample and it's being sent off someplace to be tested, then you would need to have a physician's order, because it might be getting sent to the state lab for PCR testing, which is highly complex, and you would need a physician's order. But if it is a CLIA waived test in the state of Michigan, you do not need to have a physician's order for the CLIA wave test.
And Michelle, we worked on that change, around 2015, I think we tried to implement that change.
Or it might have been before that, yes.
Yeah, but that was something Michelle and I worked on, working on the legislation to to remove state licensing, because we do have the federal program. And then just what Michelle explained on that testing, where you don't need it in Michigan for the wave test. So hopefully that answers the question.
Excellent. Well, with that, if you'd like to attend the next session in this room, it is Tax Exempt Lessons Learned, a member's story. Please stay in this room. And if you'd like to move to the other room, you will be viewing Innovations During COVID-19 Season presentation. To do so, you would click the red Leave button in the lower right-hand side of the screen, return to the conference agenda page, and click on the title of the session. And then we will begin our next session after a quick break that is sponsored by Acadia Pharmaceuticals. Thank you both for attending today, and thank you all for attending.
Thank you, Don. Take care.
Take care.
I knew about the tremors, but when I started seeing things, I didn't know what was happening, so I kept it in.
He started believing things that weren't true. I knew something was wrong, but I didn't say a word.
During the course of their disease, around 50% of people with Parkinson's may experience hallucinations or delusions. But now, doctors are prescribing Nuplazid, the only FDA-approved medicine proven to significantly reduce hallucinations and delusions related to Parkinson's. Don't take Nuplazid if you are allergic to its ingredients. Nuplazid can increase the risk of death in elderly people with dementia-related psychosis and is not for treating symptoms unrelated to Parkinson's disease. Nuplazid can cause changes in heart rhythm and should not be taken if you have certain abnormal heart rhythms or take other drugs that are known to cause changes in heart rhythm. Tell your doctor about any changes in medicines you're taking. The most common side effects are swelling of the arms and legs and confusion.
We spoke up, and it made all the difference.
Ask your Parkinson's specialist about Nuplazid.
I knew about the tremors, but when I started seeing things, I didn't know what was happening, so I kept it in.
Yeah. He started believing things that weren't true.
Stuart
I knew
and,
something was wrong, but I didn't say
and Mark
a word.
know they have to hit onto that link.
Around 50% of people with Parkinson's may experience hallucinations or delusions. But now, doctors are prescribing Nuplazid, the only FDA-approved medicine proven to significantly reduce hallucinations and delusions related to Parkinson's. Don't take Nuplazid if you are allergic to its ingredients. Nuplazid can increase the risk of death in elderly people with dementia-related psychosis and is not for treating symptoms unrelated to Parkinson's disease. Nuplazid can cause
send the
changes in
link
heart
to
rhythm and should not be taken if you have certain abnormal heart rhythms or take other drugs that are known to cause changes in heart rhythm. Tell your doctor about any changes in medicines you're taking. The most common side effects are swelling of the arms and legs and confusion.
We spoke up.
Okay.
Oh, there we go.
Yeah,
Ask your
there you
Parkinson's
go.
specialist about Nuplazid.
Theo, you should be able to hit your start video button down at the bottom left.
Yep. And I am unmuted. So.
So Mark and Derek, all right, Derek's unmuted. Mark, you're on mute.
I think I tried sharing my screen. That didn't work.
Derek, you won't be able to share the screen until this other one is finished.
Okay.
No crashing the party, huh?
All right.
Only one at a time.
Yeah.
Did we lose Mark?
No, he's there.
Okay.
I
That's
can't
it.
see him. That's all right.
Derek Betts, how are you?
Outstanding, David. How you doing?
Doing well. I thought I heard Theo.
I'm here.
Hi, Theo.
Hi. Are you our moderator today?
I am. I decided that,
Gosh, we got the big boy guns.
well, you know, only the best for the best.
I know, I keep telling you that. So, are we on for, can everybody hear us?
I think it's just us kids.
Okay, so what is this beard thing going on?
Well, it started as kind of a COVID thing. I've got mixed reviews.
Yeah?
Yeah.
The whole room hears you guys, just so you know. Okay.
So now we know.
220.
Thanks, Tom.
Thanks.
That's a close one.
Oof.
Brian, let me know when you want me to start.
Yep, go ahead, Dave, whenever you're ready.
Okay. Good afternoon, everyone, and welcome to our afternoon session on tax exemptions, lessons learned. This is going to be a really important program for everyone today. As you heard earlier today, Dr. Gordon talking about the budget circumstances that exist out there in today's world, as well as many of the other discussions we've had over the years related to the executive orders and the governor's need to find revenue. And we've had a lot of challenges of our tax exempt status through the years. You know, some of the challenges have been successful, others have not. And this is a great session this afternoon, and is one of those circumstances where the local tax assessor was not successful in his pursuit of some additional funds from a not-for-profit. So I think there'll be much more of this into the future, but I think today we're going to get a real up close and personal experience on how to defend one of those challenges. So with that, I'd like to introduce you to the folks from Thurston Woods, and Derek and Theo. Would it be okay if I let you do the introductions of your other presenters this afternoon?
Sure.
Okay, take it away, Theo.
Well, with us on our panel today is Stuart Mandel and Mark Hilbrut, who are from Hannigan, who actually were very instrumental in getting us where we're at today. So we're going to start with some polling questions.
Okay, so should be seeing my screen now, property tax exemption lessons learned. Slide 2 is just a brief description of the panelists here. Slide 3 is our first polling question. In recent years, have you been involved with an organization that owned property that was exempt from property taxes? A is yes, B is no.
Derek, while you're waiting for the answers, if you go hit your PowerPoint to go full screen, it would make it bigger for all the attendees.
It appears to be full screen here. Are you saying get rid of the, I see.
Go to slideshow on current, start from current slide. Well,
there you go.
'91 and 9.
So it looks like the answer is A, yes, 91% versus 9% no.
Okay.
All right, let's go to the second polling question. In recent years, have you been involved with an organization that received an inquiry from an assessor regarding property tax exemption? A is yes, B is no.
You got your poll going over there? You got your poll going? I see your question. Or no, it's not. Never mind. Yours comes up next.
So about 50-50, yes and no.
Okay. So 50-50. Well, if you haven't yet, you probably will in the near future. Because let me give you a little bit of history about what happened here at Thurston Woods. When we started talking about doing our independent housing development, we decided that we would have the city involved at every step of the way. So they approved, we met with the engineers, we met with the City Planning Commission, we met with just everybody within that city development. And there was a discussion about how important an independent housing development would be to the city of Sturgis. And they were so very excited about this that, you know, they were at our groundbreakings, they were here, and they were convinced that it was just a great idea. What happened then is we did our independent housing in phases. As the city decided that since we were non-for-profit, we had to pay for all the infrastructure and everything. So it meant that, you know, a couple $1 million worth of infrastructure had to go into place for every phase of development. And so as that happened, we met with the city every time. Thurston Woods Village is on the end of at the end of the railroad, end of a street at the railroad tracks. The city has always wanted to go through this street and break through the railroad tracks to connect with the junior high school across the field. We had said to them that we would be willing to help with that, and that we would be willing to actually, we committed to providing the sidewalk through our entire campus of about a half a mile of sidewalk space so that we could connect the kids from one school to another school, and it would be safer with the increased traffic. So there was a lot of discussion. There was a lot of going back and forth of commitments between Thurston Woods Village and the city about how we could make this project benefit both of us. The city was involved with our street namings. They were involved with helping us pay or make sure that the utilities went in correctly. We hired the city. We even paid for the city's people to actually do the project so that we knew that they knew exactly where everything was placed. And it was only because of the city assurances did we continue to do all of these significant development costs. Had we thought that we were going to be taxed, we would have asked for their participation as well. So the first project started back in 2020. Today's year 2000. And we finished our development around 2001, 2002 for the first phase. And all of that time then to 2005, 2008, and all of those different developments, the city has never actually said that, or never questioned whether we were tax exempt or not. So Thurston Woods has been in our business for over 65 years on this campus. For 65 years, we've never had a tax issue on our campus. We've had outside development of gifts and other things that we purchased that have been taxed, but they were not related to our mission. So as we went through this city, everything was great. We had the same city manager through it all. We had a different developer, different engineers involved, but the city manager and I have had a long, long history together. And there was never a question in his mind or my mind that we were a tax exempt organization. And then something else happened. And that was?
At the cue to change the slide there.
That was it.
You'll see on this slide, we have a new assessor that arrives. And I think he said he had just been hired about 5 years prior to the first contact he made to us. About September 2018, I received the phone call from the city assessor. He introduced himself to me, said that he'd been reviewing properties in the city and that he was researching our independent living units located here on our main campus. At the time, I didn't think too much about it. A week went by. He reached out again and indicated that he didn't think our property should be exempt from property taxes and started requesting a bunch of documents from us. We sent him all his requests. I mean, it was a cordial discussion, I guess you could say. And then a few weeks went by and he reached back out and basically just asked, you know, how do we meet the exemptions allowed in Law 211? He asked if we had any agreements with the city from when the independent living units were constructed. All these units had been built prior to my time, so I basically just said, you know, I'd look into it and get back with him as soon as I could. We dug around, couldn't find any documents or agreements with the city. Time went by, but a long story short, he said it would be our burden to prove our exemption and that he would be filing with the State Tax Commission a form L4154 to add the properties to our tax rolls as omitted property. Form L4154 is filed by the assessor. It includes a section for the property owner, which was us, to either agree or disagree with the filing. And it just seemed odd, but he asked me to fill out the explanation section, sign it, send it back to him. And if we disagreed with his findings, to explain why we thought we were exempt. I wasn't comfortable with, we talked about it, but we weren't comfortable providing an explanation of why we were exempt because we weren't sure that we fully understood the law and how to even qualify for it. I believe the Law 211 is well over 1,000 pages long. So we decided at that time we would reach out to our local attorney and inquire with him who he might recommend that were property tax experts. And he gave us Honigman LLP as his recommendation. So we reached out to them, and that was the start of 2 years of litigation.
Well, there is a caveat here that we reached the attorney that made that recommendation is one of my board members, because our attorney, and it was actually felt it was a conflict of interest, which it actually was, because he was also the city attorney for stuff here. So we were just very fortunate that we had a board member who was also an attorney here in town. So that's why he made the recommendation to go to Honigman. I just think that that's important, that small town politics, sometimes you get into situations where you really think that that person that's been your attorney forever, but they also have the attorneys for other people, that makes it difficult for them to actually help you in significant cases.
So I think this is my cue to jump in. Hi, everybody. I'm Stuart Mandel. So the city did as the city assessor said he would do. He went ahead and filed with the tax commission. And Derek, if I recall this right, at one point, he almost suggested to you that it would be no big deal for you to agree to what he had proposed in the form. He kind of invited you to go ahead and sign on the dotted line.
Right. It just didn't seem right.
Yeah. So, and in fact, and you'll see it in the next slide with the numbers, but the proposed value increases were extraordinary. I mean, they were very significant. There were over $300,000 of potential taxes at stake. And there's no question under Section 154 that the government has the right to go back 2 years plus the current year to add incorrectly reported or omitted property. This statute has been around a long time. It's mostly used for personal property because, believe it or not, there are taxpayers who don't file, right? Personal property, it's self-reporting. There's a form you fill out with cost information in the vintage year. And it has been known to happen. Sometimes taxpayers don't file the form at all. Sometimes they file it with omitted property. Sometimes the property is incorrectly reported. That's where 154 has been used the most, although it can come up in a variety of situations. We once had a case involving a commercial abatement property, and a citizen, a gadfly, if you will, who took exception to this quote unquote corporate welfare, filed the form with the tax commission. And the way the statute's written, any person can initiate a Section 154 proceeding. Here, not only was there the trouble from 16, 17, and 18, and none of this has been budgeted for because, as Theo explained, the understanding had been this was going to be exempt, and funds were invested, infrastructure monies were spent based on the understanding that there was going to be exemption. So none of this had been budgeted for, and all of a sudden you have over $300,000 of potential liability, plus going forward, there was going to be the liability starting with 2019, the 2019 tax year. And one more point to make about these 154 proceedings, you got to make sure you're timely. Exhibits have to be filed at least 30 days before the hearing, and we did have a filing. We did want to assert our position in the case, which was the property had been exempt. And we can argue about whether the property was rightly or wrongly exempted, but that's different than incorrectly reported or omitted. It wasn't incorrectly reported by the taxpayer. It wasn't omitted. It had been exempted. So, and we did, by the way, we did try to have meaningful settlement discussions with the city. The answer to the question at the top of the slide is it takes more than one party to settle a case. I mean, we couldn't settle it by ourselves. City was not interested in the slightest at that juncture in having serious settlement discussions. So onward we went into the tax commission. I think we're ready, Jarek.
This is Mark Hilpert, and Theo and I went up to the tax commission meeting where they had a short hearing on question of the city's petition and our response to it. We had stressed the fact that, as Stuart mentioned, that the property was exempt. I mean, not only exempt, but consciously exempted by the city. They knew about it. They had been involved in the approvals and the construction of the property, the financing of the property. There's no way they can somehow claim they weren't aware of it. And we were aware that the commission staff had recommended to the commission that this was a situation where the tax commission didn't have jurisdiction to change the exempt status, the taxable status of the property, relying on this Dorsey School business case. We were pretty sure that the chair of the commission was in agreement with that staff recommendation. So we went to the meeting, and at the meeting, the city claimed that they had originally thought that the property was exempt, but it was paying a pilot, a payment in lieu of tax. And that for some reason, they believed that because there was not a pilot agreement, therefore the property was omitted. And our position was, well, you may have been confused over which exemption was actually in place here. Our position was that it was a charitable exemption, which doesn't include any kind of pilot. And they believed, or the assessor initially believed, that the property was exempt under the MSHDA statute for affordable housing, which does include a pilot payment. I mean, the fact that they were confused over which exemption was in play here really doesn't support their argument that the property was exempt, or excuse me, was omitted. As the hearing went on, it became clear to us that one of the three commissioners did believe that the property should be omitted, but we thought that the other two were in agreement with us. One of the quirks of the State Tax Commission proceedings are that the parties get to make their presentations to the commission, but the commission doesn't deliberate or vote right away. In fact, they wait until after the meeting, all the agenda items are over, and then they vote on anything that's still outstanding. So after Theo and I had made our presentation, we went back and sat down and watched the rest of the meeting. And then when they came back around to vote and deliberate, it became apparent that our two votes were quickly becoming possibly only one. One of the commissioners started to waffle a little bit, and ultimately, as we watched in horror, he started saying things like, well, I could go either way on this one. And without the ability to interject at all, we watched him basically flip his vote over to the other side and vote in favor of the property being considered omitted, and ultimately the value was added to the tax rolls for 16 through 18. One issue that that the one commissioner that was really adamant about it being considered omitted was that the property record card that the city had did not explicitly say that the property was exempt. You looked at the card, it just showed a small little amount of taxable property, which was not at issue in this case. But the exempt property wasn't on there at all. And even though the city basically acknowledged they were aware of the property and were conscious of the exemption, he cited that as the reason for claiming it was omitted. Leo, did you want to add anything to our experience in Lansing?
The only thing that is interesting to me was that as I watched that interchange, the person that was so adamantly that it was omitted was new on the commission. And the guy actually said to us, or during the conversation, well, you know, I think I need to support him because he's new. And so this is his first real case. So I think that it's really important that I support him. So even when you think that you have people that are actually listening and understanding, and the person that wavered so much wasn't experienced. I mean, he'd been on the commission for quite a while, if I'm correct. And so he actually flipped his decision basically to support the newbie and not necessarily for what was actually how he was feeling during the course of our conversations, and with the questions that he was asking us to explain our position. It seemed pretty evident to both Mark and I that he was agreeing with us, and then all of a sudden, boom, he flipped. So even when you think you've got somebody in the pocket, you don't.
So we got a question along the lines of, to what extent was all of this due to just a new assessor, or was it due to a legitimate concern about the exemption? The thing that strikes me about this situation was that the city went after years retroactively for years that were not budgeted for, taking the taxpayer totally by surprise. And so it makes me wonder, was this a bit of a money grab? Because it would have been one thing for the community to come to Thurston after reviewing the documents and saying, guys, we have a problem. We have a new assessor who says he's got to follow the law. He sees you as taxable. He's the one that's got to make a decision about whether to include the property in the tax roll for 2019. His license is on the line. He's going to be, certifying the roll. And then you could deal with it on that basis, on a prospective basis. But and I think we had telegraphed to the city relatively early on. We thought they were mistaken, that the commission did not have the authority to add the property back to the roll. Mark Hilpert, you're a former chair of the commission, you can chime in. I don't think an assessor was obligated to file that 154. And I think a lot of communities would not have pursued that. They would have just raised it and addressed it on a prospective basis, unless they were really hungry for the money.
I would agree with that, that especially since there was some legitimate question about whether the exemption applied or not. And the tax commission has sent out bulletins in the last few years about instructing assessors to review rolls and look for properties that may not be exempt, that have been given exemptions in the past. But there was no real reason to go back retroactively other than the revenue situation.
I think that if you remember that when we were trying to talk to the city prior to them actually filing the taxes, we had a meeting, and that tax assessor made it known that it was his business to provide money for the city, and that he was going to do whatever he wanted to do, whatever it took to make that happen. And so he saw that as his need. So then David is asking, what do we do to make it so that others don't have that question, put themselves into this situation? The one thing that I think that we neglected to do is we didn't get our city commissioners involved. We thought that the city had the blessings of our commissioners. And that's probably the one mistake that I think we made, is that once we got the city commissioners involved and we found out that they weren't necessarily supporting the city on this, but that they were supporting us as a tax exempt organization, I think that puts some additional pressure on the city. And I think that has some influence on what the city decided to do in the end. So
yeah, I'll add two things, Theo. One, to echo your comment, it's really helpful for taxpayers to have relationships with decision makers in government, whether it's the local level, knowing your local elected leaders, your state representatives, your state senator. In fact, one of the things we can talk about a little bit about the end is the fact that at the end of the day, there's been a lot of litigation in the exemption arena. One of the best ways to solve issues, if it can be done, is through legislation. That takes having relationships with the people in Lansing. And now is clearly not the time with COVID and local governments and state government looking for every dollar they can get. But having those relationships, you know, we've had a couple clients, and this is not an exemption issue, but it's a good illustration. We've had a couple clients in recent years where they bought property and they were clearly treated differently by the assessor than their competitors. And if they have relationships with the decision makers at City Hall, it can be helpful. So you just never know when you're going to need those relationships. So it's helpful. And I guess the other thing, hindsight hopefully is 2020. I don't know to what extent it would have mattered if there had been a written agreement, kind of a development agreement back in the beginning that memorialized that Thurston was agreeing to pay very substantial development costs, and the city was recognizing that this institution was not only nonprofit, but was property tax exempt, because those are two different things. And it recognized that Thurston was agreeing to make these investments based on that exemption, that was a critical fact. You know, might that have given the city pause before going down this path? One would hope it would. There's no guarantees in litigation, but the old expression about getting it in writing, it could only have helped here.
I would just add that that probably would have discouraged the city from pursuing it, but if they really were determined to push forward, it's tough to bind them in the future regarding what the law is. And in our case, they were claiming that the law had changed, and now this property was taxable and had been exempt, even though
Well, yeah, it wasn't so
there
much
hadn't
the
really
law
been
had.
much.
I don't think they said that the law had changed as much as circumstances had changed. And so I think that it goes back to the city was looking for revenue. You know,
Yeah, the circumstance was their need for money.
yeah. Okay.
Mark, you want to talk about the numbers?
Sure. This is just a reflection of the tax commission's order. And the original valuation is a reference to that small, I think it's a small office or something that everyone agreed is and always was taxable. So there was always a small assessment on the property, but the bulk of the improvements were exempt. And this just reflects the change when the independent living part of the property was added back on. And like Stuart mentioned earlier, it was about $300,000 total in tax.
And yeah, about $60,000 of penalties and interest on top of it.
So on we went to the tax tribunal, which as a general matter, it's important to note that tax appeals have deadlines. In this case, the conservative view of the law was we had 35 days to appeal from the date of the commission's order. So we timely filed the petition. Generally, for commercial properties where there's an issue of exemption, the general deadline, for the 2019 appeal was May 31 of, it actually was 2019 back then. It actually was in 2019. And so we filed the appeal in the tax tribunal. And a short time later, we did appeal the 2019 assessment as well. Before we were done, we had not only the original appeal of the commission's order and the 2019 appeal, but the 2020 appeal. So we actually, at one point, we had 3 different cases going in the tax tribunal as a result of what the city had done. We made a number of strategic decisions along the way in terms of how to proceed in the appeals. And one of the important decisions we had made was to focus on the state tax commission order first. I mean, first of all, there was a lot at stake, over $300,000 in taxes alone. And also we felt pretty good about our legal argument. And so we did and the city fortunately agreed that this was a pure issue of law. Did the tax commission have the legal authority to retroactively add the property to the tax roll? So we were able to get a nice stipulation of facts done that set the stage for what we call dispositive motions, the motions that are going to be the basis for the tribunal's decision on this pure issue of law. And it took some time because back in, the case started in spring of 19. It was not until March 30 of 2020 that we got this wonderful decision out of the tribunal that agreed with us. And I love the last sentence of the tribunal decision. The last sentence of the tribunal decision said, the commission does not have authority to add value to the assessment roll that was included in the assessment, but erroneously exempted from taxation. And we would argue the property was not erroneously exempted, but even assuming it was, the key was the assessor could go back and fix value, but this wasn't a value question. It was It was the exemption issue. And so we got this wonderfully favorable decision, which that really, I think, took the wind out of the sails in the city. And that's kind of what we were hoping for when we made the strategic decision to focus on this and make this the priority. We were hoping that if we could win this issue, now all of it, we're at a juncture where there's not as much upside for the city, a lot more downside. They had already incurred a fair amount of cost in this proceeding and had just lost. And sure enough, it brought them to the table. I think we're ready for the next slide.
All of a sudden, you have to think about what you want to do, how you want to do it, whether you roll over and pay the tax and say, okay, when I talk to other people in the industry, yes, they have independent housing be taxed. Yes, they just add that tax onto the independents entry fees or into their monthly fees. Yes, there is the probability there was always a chance that we weren't going to win, but it came back down to what was right and what was true and what was honest and what was legal. And we had to think about how we were going to look our residents in the face and say, we just rolled over, or we're going to fight this until we win, or we lose, but we're going to give it a good fight. And I think that it was a lot of time. There was a lot of stress involved. It was an intense time. There was a lot of harsh words said back and forth through the city. Derek spent a lot of time on the phone trying to reach our city commissioner, who happened to be wintering in Florida during all of this time. And then when he came back, he just more or less blew a stack because he was not aware of anything that was going on. So we had to actually think about all of this as we were going through this tax issue in a small rural town where everybody knows everything. But for some reason, nobody knew anything about this except the city commissioner, the city manager, the assessor, and the treasurer, the city treasurer. Everybody else seemed to have either their head in the sand or were out of the loop. So I think that even when you think that the city is small and that everybody knows everything, one of the lessons that I learned was that sometimes you have to press the right buttons to know what happens. And then you have to also understand that other things happen within the city as well. And I think that one of the things that the city learned is that we were not going to roll over. We were just not going to say, okay, you won, we'll pay it, and we'll charge it to our residents and be done with it. So we knew that when we were going through this, that we were hiring the best attorneys we could find. And you want to be really aware of the fact that no time during this whole conversation with Stuart and with Mark that they said, yes, it's a slam dunk, we're going to win this. What they said was, we're going to fight the fight, we're going to do it the best that we possibly can. Because if you have somebody that says, yes, it's a slam dunk, I think that the lesson we learned through the tax tribunal was that nothing's a slam dunk, because we really thought, Mark and I really thought we were going to go home with the win way back in 2019. So then what happened was after we won the initial the 2018, 16, 17, and 18, and the city knew that they were going to have to pay that back, they started thinking, okay, what can we do? How can we make it a win-win? And so that's when the settlement, the agreement, the negotiations started. When it's all said and done and the rest, when it's all history, you have to step back and say, would I do it all over again? And our answer is yes. We would do it again because it was the right thing to do. And we really felt like we had that on our side. So we actually agreed to pay taxes. We came up with a negotiated tax moving forward so that we will pay what is about 53% of the original amount. So about half of what the city wanted. And our residents are thrilled with that because it's a significant reduction in their expense as well. Because in 2020, in January 2020, we started billing the residents for that tax. So now we get to give them a refund and they're thrilled. They think that we walk on water because we actually won, and they're pleased. I talked to somebody from the schools. They're not so pleased because they have to take, they have to send monies back, but it was the right thing to do. Okay. Do you guys have anything else to add?
I just say this, and this last slide tells the story. The first case on the slide is the Wexford case. I handled that case from start to finish. It was about a 5-year journey. That is the leading case for charitable institutions. And the Wexford case actually is a very well-written decision. But I want to point out, we lost in the tax tribunal. We lost in the Court of Appeals. And actually one of the justices, I'd been before her several times, she always voted as I argued for. But this time in Wexford, she didn't. So we lost 3-0. So we had 4 judges all telling us we were taxable. The Michigan Supreme Court took the case and unanimously granted exemption. And basically the test of whether you're a charitable institution, it's a 6-factor test. There's a variety of factors. But I think it's a very well-written decision. And then all these other cases that you see here are dealing with more specifically the housing type of properties. And Mark, I don't know if you want to speak to this. I'll just say, early on, the Baptist Homes case and the retirement homes case, the taxpayers got the short end of the stick. I think Justice Markman, most recently in this middle case, was willing to revisit those earlier cases in light of some of the more recent cases. Mark, maybe you want to jump in here. I think there was an opportunity for the court to right some prior wrongs, maybe.
Yeah, I would add that before the Wexford case, this charitable exemption question there's just a patchwork of case law, and different courts would focus on different criteria and you would get all kinds of different decisions. And this went on for years. And the hope was that Wexford would kind of set the standard with those 6 tests and add some clarity and guidance going forward. About 10 years after that Wexford case was decided, another case got up to the Michigan Supreme Court called Baruch versus Tittabawassee Township. And it was unusual in a way because as a non-lawyer, I always am a little frustrated when courts decide a case and don't do anything other than resolve the case when they could offer guidance and some clarity as to what the law says, at least from their perspective. But in this case, the Supreme Court did that and more. They offered examples. They pointed out cases that where the lower courts had not applied the Wexford standards properly. And in particular, they wanted to clarify this one factor from Wexford that says that the charity can't discriminate against the beneficiaries of the charity. In other words, they can't arbitrarily discriminate. The case, Baruch, involved an adult foster care facility. There were no financial disclosures required. You had to have Social Security, and then there was a special income-based program. But the key thing for the case was that there was an acknowledgement that charities can't provide benefits to everybody unlimited, and that they can charge a fee for their service to maintain their operation, and they can also apply a way to restrict or allocate their benefits so long as there's a reasonable relationship between that and their charitable purpose. In other words, they don't have to do an arbitrary decision like have a lottery or come first serve, for example. So that was in 2017. If we go back, fast rewind about 50 years now to the 2 cases that Stuart had mentioned, both involving senior living facilities. The first one, Michigan Baptist, involved a life lease fee up front. And the court there said that charity must benefit the public without restriction. And this particular situation, the facility did not serve the elderly generally, but provided attractive retirement environment for those among the elderly who have the health to enjoy it and who can afford to pay for it. And they said the ability to pay the taxes was the primary factor in determining admittance or not. And then 4 years later, you had the retirement homes case, similar, except that there was no upfront life lease fee. It was just a monthly fee, and the idea was from the petitioners there that the absence of that upfront fee should have made the difference. But again, the court said that, hey, there's no gift here for the benefit of an indefinite number of people, or for the benefit of the public generally. In that they pointed out that the rent was about market rent, and the fees covered all the costs. So if you take those 2 cases and you think about it in terms of Wexford and Baruch, there seems to be a conflict. And as Stuart mentioned, there's been a recent case called United Methodist that went to the Court of Appeals, and it involves specialized assisted living. And in that case, the petitioner argued that, hey, look, we have to acknowledge that the charity can't provide unlimited benefit to all the public. They have to decide who to, they have to have a reasonable basis for allocating that. And they also argued that this Baruch case overturned Michigan Baptist and retirement homes. But the Court of Appeals disagreed, said really Wexford and Baruch just dealt with the question of what constituted a charitable institution, and it did not deal with the question of whether petitioner was using that property for their charitable purposes. I think that's kind of a dodge, but that's what they decided. And so it was appealed to the Michigan Supreme Court. And as Stuart mentioned, the Michigan Supreme Court last year denied leave to appeal, which means the case stands. And Justice Markman specifically dissented on the question of whether the case should be taken. And he pointed out, among other things, that the reasoning in those two earlier cases, Michigan Baptist and retirement homes, was the same logic that was basically rejected in Baruch. And also that Baruch is the more recent case here, but if those other two cases allowed to stand, and somehow the court doesn't reconcile Baruch with those two cases, you could have easily situations where an entity, charitable entity, would qualify for exemption under the Baruch standard, the Wexford and Baruch standards, but fail to get the exemption under Michigan Baptist and retirement homes, which would ultimately mean that they would not get the exemption. Yet the more recent cases are the ones that would grant the exemption. So unfortunately, in a lot of ways, we're back to where we were before Wexford on the particular situation of senior living facilities. Assessors treat these differently. Cities and townships tend to treat them differently. And unfortunately, it looks like and the cases are very fact specific, I would add. And it would seem that we're not at the point where there's going to be an end to that litigation on this question. That was all I had on that question. Anybody have any questions on the cases?
Do we have any questions out there?
The only question I see has to do with how the attorneys view the strength or weakness of Michigan's case law in general.
Well, I'll go first. So I think Mark and I probably would agree Wexford is a good decision. It's the right decision. Does a nice job of articulating the standards. But as Mark just explained, we've got a hanging chad out there, which Justice Markman is retiring, but he's a pretty smart guy, and he nailed it. He said, look, we have inconsistency out there. We really ought to take this case and clean it up. Court decided not to for whatever reason, and you just never know what the justices are thinking. But they didn't, and so again, to my earlier point, I think if there's an opportunity in the future, thinking long-term, a year from now, 2 years from now, 3 years from now, if there's an opportunity for groups to work collaboratively to try to change the law, that may be the best way to get clarity and a favorable resolution, because as you've seen, having these things litigated piecemeal, it's expensive, it's stressful. You cannot, beware of lawyers who promise you victory. You can't predict what the appellate judges are going to do, let alone the tribunal. And litigating each of these is costly. So I think unfortunately that's the state of where we're at. Mark, you're welcome to chime in.
And no, I agree with you. And like we said, nothing really protects you ultimately against having some new assessor get hired and decide he's going to review all the exemptions and decide that your particular one no longer meets the test, and he's going to put you on the assessment roll going forward, at least, and possibly might try the same thing the assessor in Sturgis did. Try to go retroactive.
Thank you. We have another question. What suggestions would you offer to listeners to proactively avoid these types of situations?
So one thing to do, again, relationships are important. Make sure you have good relationships with the local elected leaders who ultimately make decisions. And let me note this, it's true that the assessors have control of the assessment role when they make the assessment. But once you're in the tax tribunal, the local council or board for the jurisdiction, whether it's a city or a township, it's their decision, and it's like any other lawsuit. In Thurston's case, we were able to come up with a settlement that kind of pretty much split the baby and settle it that way. Sometimes the elected leaders may disagree with their assessor. There have even been cases we're aware of where the assessor ended up leaving the jurisdiction because the assessor was not okay with the way the jurisdiction wanted to handle certain properties. So those relationships are just invaluable. And then obviously, you got to be careful with any communications. I think Thurston was wise to get us involved. I don't say that meaning necessarily just us, but just to have expertise, to have people like Mark, former chair of the commission. I've been doing this for over 30 years. To have people involved who have experience, even from the beginning, if you get a communication from the assessor. Sometimes we get involved in things and people have tried to handle them on their own and unfortunately only made the situation even worse. So I think one thing to do is if there ever is a glimmer of trouble, get good professional help right away. Mark, anything on your end?
I would just add real quickly that we run into situations often where someone has a problem and they approach the assessor says, oh, we can talk about it, or maybe I can fix that. And while that discussion is occurring, you're missing an important appeal deadline. And even if the assessor is delaying in good faith and wanting to resolve it, once it's beyond the appeal deadline, or it may be to the point where they don't have the authority to make the change at that point anyway. So don't forget the appeal deadlines.
I would say one of the lessons that we learned is that we had conversations with the assessor for several months before we actually got notification that he was going to actually tax us. In hindsight, I think that we should have probably, that first initial phone call should have alerted us to something significantly was in the works. And I think that that may have made it, given him the understanding that we would just pay it no matter what.
Excellent. Thank you. I don't see any further questions at this time. So we'll go ahead, and I would just, before we move to our closing comments for today, I would like to give a big thank you to Theo, Derek, Stuart, and Mark for attending today and providing us with their insight. We are incredibly grateful for the time they spent with us today and the relevant information they shared, and it'll surely be helpful for many of other Leading Age Michigan members as they face similar challenges in the future. With that, I'd like to move to comments from Dave to close.
I guess we're off.
Yeah.
Good afternoon, everyone. It's now about 3:30 in the afternoon, and it's time to conclude today's programming. We hope you enjoyed the first day of our Leadership Institute and also learned a thing or two along the way. Tomorrow we begin back here at 9 a.m. for another great day of education and planned activities for you as well. In closing, I'd like to encourage you to continue to support the business partners that support all of us. Thank you to our GPO partners, Omnicare, Therapy Management, and Value First. Without you, we can't do the things we do for all of the members every day. Additionally, I'd like to thank our Leadership Institute sponsors, King Scott, Arcadia Pharmaceuticals, and our good friends at Ziegler Financial Services. Thank you to everyone who participated, and I'll see you in the morning. Have a great evening. Bye now.
Bye, guys. Thank you.
Thank you, everyone. Have a good evening.
Yep.
Thank
Bye
you.
now.